so many babies are born, but how many of those have congenital anomalies? So that is not captured in the, we don't have data elements to capture that. Therefore, my request is, how can we harmonize these data elements? And then or part B, while DHSIS2 captures these selected congenital anomalies, the categories are the congenital anomalies. There is need to disintegrate that so that you don't put in one basket. Thank
you so much, Dr. Semanda, for all the comments. You gave in some responsibilities or questions to the RDC Amuro. I think you can respond, then we can have other people speaking.
Thank you. You know, these days I'm a health expert. And it is very interesting. I think because of our location, more especially in the areas of the town council, that is where we register these open defecations. And this attests to the numbers of people in that area who are homeless per se. But as resident district commissioner of the district, you're aware that these are sanitation measures that we need to take. And I want to affirm commitment of government and my office to address this, because you have identified it's now a public health risk threats which we'll be able to address. Because I am happy always when I come in a meeting like this and we identify challenges that affect us, and we'll be able to mobilize the community. And the best thing is we have just started a new government of no sleep. So the no sleep, by next week, you'll read a directive from the resident district commissioner more, directing the chairperson of MC3s to ensure that all households have what is necessary in their homes. That represents a latrine. That one is not a work of DHU. My office will take it. It will be a deliberate action, which will take. And I will now require another district with such cry. In Amore, it will die. And that commitment is done. Thank you.
Thank you so much, RDC, for that words of affirmation. We wait to see it mature. Over to you, Dr. Pebala.
Thank you. I think I'm happy that my brother, RDC, is giving a very good directives. And I think this will also include farmers in your district to have pit like fields next to their farm, not only their households. Because I think quite a number of farmers take workers into the farm, they do whatever it takes to ease themselves. Thank you. I wanted just to say one or two words about the data, and thank you so much, Raymond. I think this is a very rich data that we can do a lot. As Gulu Hospital, as actually sub-region, I think we've done a good job. I think we need to appreciate ourselves. Yes, the statistics does not show a very clear pictures of what we're doing, but I think a lot is being done behind this. Of course, there are many challenges that occurs, and then probably many of these things are not reflected. You see, first ANC attendance is very low, and then probably attended late and whatnot. Some of these people actually probably register in other private clinics that do not report to the districts, and a lot of this data are lost. Not that they don't attend, probably they attend conveniently because they just want to walk in, do whatever it takes, and then probably we need to track down some of the else centers, probably private or something, that do not report to the district, so that we invest as much as we can to have a clear these pictures. Cesarean sections will always rise, whether you want it or not. I know some people are proponent of the idea that cesarean section rates should reduce. No, it's not going to reduce. If we want clean perinatal health, we have to embrace cesarean section. The only way we can reduce those perinatal deaths, those intrapartum deaths, is when we embrace cesarean section. And then the more you do cesarean section, the more you create people with previous cesarean section scars. That means that the population keep building of those with previous cesarean section scars. So with the time, it keep increasing. Whether you want it or not, it will increase. And also some theory that is not very clear is that babies' head circumference have been increasing over the decades. That's why your babies these days are smarter. When you see a young baby and you look at yourself when you're young at that age, this one's are smart. Okay, so probably the head circumference is increasing. You need a sharper baby, but the pelvic circumference is not increasing. So definitely, in some part of the world, the kids age 50%. In some hospital in Uganda, we are at 70% cesarean section. And also, for us providers, cesarean section, if you want to reduce a lot of litigation, you might need to have a low threshold of deciding when you should do cesarean section, because you're going to go to court, you're going to lose your license. The hospital will be held accountable. There was certainly private hospital is coming to government hospital in the future. But I think it has also really come to some government hospital. Okay. So you need to have a lower threshold when you should actually do cesarean section. And that's something that happens. But also the obstetric population keeps changing. Like if you look at the obstetric population that attend Gulu Regional Referral Hospital, it's different from the obstetric population that attends Lacho Hospital. That's why the cesarean section rate in Lacho is higher than Gulu Hospital. Not that we're not doing well, we're doing very well. Okay, with our population, we have the right rate. Lacho, with their population, they have the right rate. So you don't need to compare the two hospitals. Just look at the rate of Lacho, look at the rate of Gulu and say, I think the other hospital is doing well. No, you need to understand the drivers of those, and that's importantly the obstetric population. So that's something that I thought I should throw around the cesarean section. Thank you.
Thank you so much, Dr. Fegalo. He's also our specialist. He made a point and I wanted to ask him, why is it that the baby's head circumference is increasing? What has changed in the pregnancy period for the mothers, that the pelvic diameters are not changing, but the head circumference is changing? Is there something they're doing special for the intrauterine fetus and they're not doing for the mothers? So should we anticipate in 50 years from that the heads will even be bigger than what we see now?
Answers to that. But definitely epigenetic will go a long way in the direction of what you're going. If you look at the maize plant that you like now, the crops you buy along the roadside, it used to be a very funny grass. But because we tend to grow to that direction, we enhance the crop. So probably we're enhancing our brain more than our pelvis. Thank you.
Thank you so much.
Yeah, thank you so much for the data which has been provided. I just wanted to to react on to respond on some of the observations which I've so far seen. I work with private facilities, which I've noticed that the first ANC visit has been reducing because more especially the working classes. So you find the working classes, I notice when they come to the facility, they always trust their AL and internet, and they serve most of their drugs from the internet. And they will clarify to you that the reason why we come up to the third ANC visit. And that means we need to not only to focus on those who are in the villages, we need to focus on the working classes. And you capture this data, you find most of the working classes, they don't have time to come for first ANC visits. And that is something which I've noticed so far because they depend on what they read on the internet. Another observation which I've seen on the teenage pregnancy, I do a lot of community dialogues and some of the neighboring districts when I could support some of the private facilities. So you find the teenage pregnancy, majorly, we have neglected sensitization, more especially of sexuality education to the young people. And the challenge also on our service provider, they do not have time to have adolescent health, and they have that kind of interaction so that they can be motivated to come for some of the services, more especially the family planning. And instead, you find some of the service providers, they are the ones discouraging these young people to come and take up family planning service or any other information regarding the family planning services. So it is upon us to see that at least we can be able to convey the message in terms of information so that at least they can take up the service. Thank you so much. This is my observation. Thank you.
Thank you so much, my new friend from AAR. Thank you, Doctor. So colleagues, because of time, we're going to have the last two submissions regarding Raymond's presentation. And then we go to the next one. The hands are increasing. Oh, let's first have the last two.
Thank you so much, MC. Again, my name is Akelo Harriet. I work with Mother Health International as the director for midwifery and community outreaches. And I welcome my DHO is around, Dr. Kelo. You're most welcome. So, Raymond, thank you so much for that data. And I love the first conclusion of your recommendation, the first conclusion you made. And looking at your statistics, it's good that you're giving us work to do, and I'm impressed about it. Recently, this is a point of information, recently WHO rolled out that countries should transition to what we call the midwifery models of care, because they believe that about 80% of care that can be given to pregnant women throughout pregnancy, delivery, and postpartum can actually be provided by the midwives. And one of the key things that they have also highlighted that we should stop looking at mother life and baby alive. So looking at the figures that Raymond has given, he's only showing us figures, but we have left out the experiences of women when they come to our facilities to receive care. So now we are looking at the numbers of institutional deliveries are happening. Where are our women delivering from? You get that point? Where are our women delivering from? In his first recommendation, he said that we need to strengthen linkage between the facilities and DHTs or community health workers. It's a very key and a very important recommendation, because me and Dr. Pebalo, me a midwife and him a doctor, we can only deal with the last delay that is causing most of our death in the facilities, right? But the first delay and the second one is happening in the what? In the community. And she brought a very important question. Male involvement, late antenatal care. It happens in the community. You can't pull a mother from home. But if we strengthen our community health worker involvement in maternal and child health, we are going to we are going to see a lot of improvement in our outcomes. And then I also wanted to comment on, I was a little scared about the institutional death Don't you think our community has known that women die in the hospital and now they have resorted to the TBS and they're actually not coming to us? So Raymond, beyond the statistics, please help us also find out what are the experiences of women when they're receiving care in the hospital. Thank you so much.
Thank you so much, Harriet. And I think she's one person or one midwife who is very passionate about community engagement. In Amor, she's doing a tremendous job. That's why in every sitting, she'll not forget to talk about the community where mothers come from. Thank you, Harriet.
Yes, thank you very much, MC. I'm Dr. Clinton Apio. I'm the DH of Adago District. I would also request the RDC, the whip of the RDC, to also extend this directive across the entire region so that this issue of identification is addressed at once. I appreciate your concept of evolution that is happening, but I think if we can share with us some study on the change in the head circumference vis-a-vis that can inform us better. My question to Raymond is, in the presentation, I think some slides stood out where July 2025 to March 2026 had more rates than the previous financial years. You realize we are moving from paper-based to digital, and the government has stopped printing the registers to capture data, and they also stopped implementing patterns from supporting along that line. And these excess registers that were there, I think they're now beginning to run out, and some facilities have really not migrated yet to digital world. An example is Kalong Hospital. Called me recently and said for them, they don't have EFR. The paper register is also running out. So what should they do? I was supposed to respond to them today, and I knew I was going to meet you. So I was supposed to meet you privately, but now I think it's good for all of us, this information. So how much has this impact of us not having registers and yet we've not migrated to digital world contributed to this kind of data, especially for looking at I know we're doing a lot. If I see ANC1 declining, I ask myself, why is it happening? Yet every day we are compounding on the information again and again, and yet this is a very critical indicator as far as health service provision is concerned. So would there be a reason this absence of registers is contributing to this?
Thank you so much, Dr. Clinton. Before you see it, there was a question that was actually raised to the DHOs in the House about the functionality of the CMOG facilities in your districts, the health center force. If we saw the statistic was showing that institutional deaths are very many in the cities, and then in the districts, it was very low. And the question is, what is happening? Are the facilities that are doing the other services, the CMOG sites at our district levels, are they functional? Or those are the mothers we are receiving them all at the facilities? And if they are referring them, how early or what is the referral practices? Do we practice timely referral? What is the functionality of your CMOG site? There in Agago, that is Atongo. Yes.
Yes, I know the question. Okay. I forgot it. Let me respond to that. Yes, the functionality of the CMOG site in Agago district, especially that one health center for, is not the best at the moment. And I think for the next foreseeable future may not improve very much. Of course, we are making interventions. Hopefully, within the week, I'm supposed to also speak to the LNS coordinator about that and see what they can do, because they're supposed to come and empower us there next week. But basically, because of one, the medical officer who has not been there, and we've not managed to recruit a medical officer. That's why I say in the next foreseeable future, we may still have that challenge, specifically for Patron. So that what does it mean? It means Patron does a lot of referrals, and in terms of referrals in Patron, we really make time referrals to Dr. Ambuzoli Memorial Hospital alone, and that is what we do. I think it's timely. We always follow up and make sure the outcome is right. And I've not had a very bad outcome. In one of the engagements, I think I don't say the people who go there have bad outcomes, but when I went and reviewed case by case, I didn't see much, but yes, we'll still continue referring as a Target district, especially Patriotic Center, for which is only one and doesn't have a medical officer, except for the one whom we have is actually on sick leave. And I don't know whether she will come back soon. But I will do something about that to make sure that we have someone to stand in to act in nice safety. Okay, so that is it. About the other smoke side, Ambulatory Memorial Hospital is actually functioning very well and supporting our elderly schools. Thank you.
All right, thank you so much. He has answered actually in regards to Agago, and we have other DHOs in the house here. Maybe they give a quick response of what is happening in that district.
Thank you. I'm answering on behalf of Lamo. I must say, Lamo, we are improving drastically. Center 4, which was commissioned 2 years ago, was previously having only one medical officer with us. But currently, we have 3 medical officers. Our great appreciation goes to UNFPA, which has given us the latest one. We also appreciate MDI for providing another to add on the one of government. Also previously, we had only one anesthetic officer at Palamekal, Center 4. But now, also with the help of MDI, we have another anesthetic officer. So then, and so now Palamekal is constantly 24/7. Any part going out should be something which is more serious. On the side of Padibe, on the same note, when IRC contract elapsed, I was also remaining the only MO there. Fortunately or unfortunately, also acting as DHO. But I'm also grateful when I relayed my pride to the MDI National Coordinator, who happens to be my good OB. He gave us an MO. And also Refugee Law Project is helping us with another MO. And adding on to another volunteer who came last month, we already have 3 MOs. And I'm also inclusive for any eventuality. But MDI also added for us another anesthetic officer. So we have now 2 anesthetic officers covering the SN 24/7. Our major challenge now remains with Mali Obey SN 4, which has only 1 anesthetic officer and 1 MO. I am very grateful to report to the House that Lamo District Local Government has 4 MOs. Okay. As 4 doctors who are doing interns, and soon they will become MOs. 2 of them are finishing this month, and immediately I will post one to Madupe to cover even weekends. The unfortunate part of Lamo District Local Government is that much as we also have only 1 anesthetic officer who is on government payroll in Madupe, SN 4, I had put in my improvement plan 1 anesthetic officer to be added, so that also Madupe is covered with 2 anesthetic officers. But unfortunately, due to some circumstances which were beyond us, recruitment did not take place. But I am also grateful at the same time to report that I have seen our latest IBF, which is now our approved budget for this financial year, and we have additional wage at the department. Recruitment of an anesthetic officer will be first as my priority, so that Madupe is also covered as soon as possible. I think after that, Lamo will not be having problems. But as of now, we have a lot of great improvement. And I know Kitboom is a little now comfortable with us because we are not sending a lot of referrals. Thank you so much.
Thank you so much, DHO. of Lamu district. Colleagues, we are also very excited to have our online participants who are very engaging, and we don't want to leave them out. So we have some comments from our online families, and they're also giving critical inputs here. One of them is saying that, first of all, it starts with us, the midwives, to advocate for male involvement. It's our role to advocate for male in the church or any other gathering that we find ourselves in. Thank you so much. That is Miss Brenda Nakita, all the way from Kayonga. We really appreciate your participation in this conference. And another person is saying, you may be surprised, sir, that it's all knowledge gap. It's beyond not having time to attend antenatal. This is, I think, responding to the comment of one of our doctors who is from the private practice about educated women who are really attending antenatal visits very late and others. So at this point, we also give opportunity to our online members. If you have a point, you can as well raise up your hand and we give you the privilege to also speak to us. Thank you so much for sacrificing and attending our conference. We don't take that for granted. So colleagues, I'm going to give the last, I'm going to give Raymond to respond to these few questions as we organize ourselves to go to our next presentation on the agenda. Thank you. In case there is anyone from online, we shall give you the time to speak to us. Don't hesitate to raise up your hands.
Thank you so much, so much for the response for the questions, and some of the questions that were asked have been responded to. So some of the participants straight away go to the question that was asked by Mr. Jonathan, so the 20 officer from Regional Referral Hospital, working on the way from those other abnormalities that you reporting for, especially for the children. What that one can be done, they were now implementing the already revised tools from 2020, they were revised in 2024 up to 2029 for 5 years. So we shall have to wait towards the period of 2029 and giving that feedback so that it should be taken up. But for now, it's something that is difficult to handle at this level. Then secondly, for the challenges with ear fear is the system that is being used mainly in health centers and hospitals. Public health centers and hospitals are already enrolled on ear fear to place the hard copy registers. So for that system was launched when they had some few gaps which the developers keep getting feedback, and when you share the feedback with them, they improve on that system. So the users are being usually reminded to share that feedback to us, so that also escalated to them and they improve, because there's a system that was adopted from Kenya now to here, so it's not yet fully integrated to the tools that we have been using, especially at registers. Then for facility, for like Kalungu Hospital, that what should they do for now that they can enable to breathe and they not have the EFR system? For that question, I will answer Dr. Givington. By the end of this conference, I'm going to consult with the Division of Health Regulation on what they would do, because for them, they are in the hospital, they can't implement the digital registers that are being implemented at health center 2 and health center 3. And for the PNFPs that are ready to implement those digital registers that are at the level of health center 2 and 3, they are welcome to utilize it, because they can get trained and given the right necessities and they start using it instead of printing the registers. But for the hospitals that are not public facilities, we need to consult and give feedback before the end of tomorrow. Thank you very much.
Thank you so much, Raymond. Thank you so much for giving us a brilliant response and way forward. I think to also say something on what Harriet has said, I think that is under client feedback. And we have the regional QI who has been so much passionate about this. If he maybe finds time to join the conference, we can also give him that question and he give us what he has in regards to that. So colleagues, as we welcome the next presentation, I want us to come to conscientious. It is already 1:50 p.m., which is lunch hour. So since we took our breakfast late, we would want to request the room that we give ourselves some 30 minutes so that we have a presentation of abstracts from our colleagues, then we go for our lunch break. Is this okay with us, or we go for the lunch break first? We have the abstract presentation? All right, thank you so much. Now, at this point, I want to welcome Jacqueline Aikoro from the university, who is going to moderate this session of abstract presentation from our gallant researchers that is going to inform us about what is really happening. What are we doing? Let's give Jackie a hand of applause as she joins the room. Thank you so much.
Hello. Hello. There is a saying that goes that work without play makes Jack a what? I would request before we proceed with the presentations, can we please rise up for a minute? Anybody with a nice Bongo, could you please give us an icebreaker?
Write your name using your waist. Okay? So if it is B, I know my name is E. Then O, then N, E. Okay, so write your surname, please. So we start. 1, 2, 3, we go. Thank you.
Thank you, Dr. Bongo, for that. Well, for the next session, as we settle, we are going to invite our presenters. We have 4 seats there, and we are going to have them all at the same time. So every presenter is going to be given 7 minutes to present, and then we will note our questions down, and we will have interaction with them. So our first presenter is Dr. Otita Donald. Dr. Otita Donald, as you step forward, he is an intern doctor at Gulu Regional Referral Hospital. He's also a research fellow at Gulu University Faculty of Medicine at the Department of Medical Microbiology and Immunology. Today, he will be presenting his work on a study that he has done on exclusive breastfeeding. The second presenter is going to be Dr. Douglas Otto. Dr. Douglas Otto, as you step forward, he is a public health specialist, especially specializing in population and reproductive health. Douglas is also very passionate about improving access to high quality reproductive health and family planning services using research evidence to inform policy and program implementation. Today, he will also be presenting his work that he has done on modern family planning methods and associated factors among HIV positive women of reproductive age. Our third presenter is Miss Adong Rachel. Miss Adong Rachel, as you step forward, she is a midwife at Soroti Regional Referral Hospital. She is also a specialist in sexual and reproductive health, and she has a bachelor's of science in midwifery. She is also a national trainer for quality improvement and post-abortion care and family planning, and also reproductive health commodities. She's a member of the National Midwives Association of Uganda, and today she'll be presenting her work on enhancing IUD uptake in Soroti Regional Referral Hospital. Our last presenter for this session is Ms. Christine Dimio. Mr. Christine, as you step forward, she is the Principal Nursing Officer of Gulu Regional Referral Hospital. She has also been a professional fellow in the UK and Malawi. And also today she'll be presenting her work on institutional and environmental factors that influence performance of nurses and midwives at Gulu Regional Referral Hospital. So those are all our presenters for this session. I would love to invite our first presenter, Dr. Donald Otika. Please, the floor is yours. You can take on the presentation. And as you prepare, know that you have 7 minutes to complete your presentation.
It is a very great honor and pleasure to be the first presenter of such a dignified panel of participants, and I do not take that lightly. Good afternoon, ladies and gentlemen. We have so many people in the audience today. I will not take a lot of time to introduce everyone, but protocol observed. Before I go into this abstract, today morning, before we came here, I had a light casual chat with my friends, and we were talking about a mother who was coming from somewhere here. An 18-year-old mother who was pregnant for the first time, did not go for any antenatal visit at all, delivered from home to a bouncing, beautiful baby girl, did not come to hospital for anything until she was delivered by her grandmother, who promised her that I know these things, I have done this thing before. After 12 days, she developed puerperal sepsis. Child developed severe neonatal sepsis, and they only came to whatever hospital they went to because of that. And unfortunately, the child could not make it. Now, as we are discussing health indicators, the work is still far from being done. Before here, we had talked about TB, we've talked about maternal indicators, we've talked about DPT3, and Raymond made mention of 0 doses, which are out there. I also want to tackle a very important aspect of child health, and that is exclusive breastfeeding. And this was an academic study that we did while we were still at the university. First of all, like we have said, exclusive breastfeeding by WHO standards, this means that we have children who are being fed on only breast milk for at least the first 6 months of their lives. And we are saying that there is a lot of effort globally and also nationally on scaling up exclusive breastfeeding. However, there is still a lot of gaps, especially in the completion at 6 months. And Uganda specifically, more especially in this region, we are seeing that newborns are exclusively breastfed, but as they grow towards 6 months, the proportion of children who still remain on EBF start reducing, especially from 3 months of age. And this contributes to a lot of preventable health complications that are out there. So in this study, we aimed to investigate the prevalence of exclusive breastfeeding completion. How many children are being exclusively breastfed up to 6 months? And we did this study in Gulu Regional Referral Hospital. This study was conducted between July and October 2024. We enrolled a total of 223 mothers who had children above 6 months, because we wanted them to know how many of these mothers had breastfed their children up to 6 months. We used convenience sampling to recruit our participants. And we used a semi-structured interview administered questionnaire. And all this data, we analyzed it using Stata 17. In analysis, we used descriptive statistics to summarize the prevalence of EBF completion at 6 months. And we used Pearson chi-square and Fisher's exact tests at bivariate levels. And we also used modified Poisson regression with robust variance at multivariable level. We included those variables with a p-value less than 0.2 at the bivariate in the multivariable model, and any variable that had a p-value of less than 0.05 was considered statistically significant. What did we find? Our findings were both exciting and heartbreaking. We looked at, from the population that we were able to enroll, only 152 of them reported that up to 6 months they are not given anything except medications or anything. And we can see the majority of the percentage, the other side, about 61.4%, reported, this was self-reported, reported that maybe somewhere around 3 months or 4 or 5, they started supplementing with various reasons that cannot be projected here. But interestingly, we also wanted to look at what are some of the things, what are some of the factors which could either favor or not favor completion of exclusive breastfeeding at 6 months. And this is some of them that we could come up with. One of them, the topmost that we can see, was perceived importance of exclusive breastfeeding. The mothers who perceived the importance of exclusive breastfeeding were almost 22 times more likely to complete 6 months of exclusive breastfeeding. And this was statistically very significant. Also, we looked at those who attended healthcare programs. Mr. Raymond was talking about the community health sensitization programs that can be done for different purposes, but also we saw its importance in exclusive breastfeeding, that these mothers who attended some of these programs, either in the community or in the health facility, were about 10 times more likely to complete 6 months of exclusive breastfeeding. And that as well was very statistically significant. Also, those who had community support towards community support specific for exclusive breastfeeding. We also saw that these people were also able to complete 6 months of exclusively breastfeeding their children. Then level of education came in there, and family support for breastfeeding specifically was also seen to be an important factor. And this could also cut across with what my sister said about husband support. So when we talk about family support, I think it is multifactorial. Whether it's husband or a sibling or a parent, those who had this kind of support, we saw that they were able to exclusively breastfeed their children up to completing 6 months. But also we looked at something else. We looked at a twist mothers who were regarded as grandmother parents, those who had 5 and above children, were actually seen to more likely not be able to breastfeed their children up to 6 months. Maybe because of familiarity, or they think they have been there before and nothing has happened. So these are the mothers whom we were seeing. Most of them were stopping at maybe 3, 4, 5 months and starting other things. And what do these findings tell us in conclusion? These findings, first of all, will highlight that in this region, or in the facility where we picked these findings from, completion of exclusive breastfeeding is suboptimal. WHO recommends up to at least 50%, and we saw only about 34.9%. That means we still have more work to be done in case we want to improve on the morbidity and mortality that is linked directly or indirectly to exclusive breastfeeding. But we also looked at some of the predictors like maternal education, which was very important, family and community support, like we are talking about holding community dialogues, encouraging husband involvement in the support of these mothers, and healthcare programs, which we have already made mention of before, and then also changing the perception of these mothers towards the importance of exclusive breastfeeding. Some of these are going to be very important in enhancing the health of these children, and of course reducing the mortality rates that are involved. Also, the other way, like we already saw in our in the research section, we saw that mothers who were grandmother parents, and something else we did not reject is about the poor maternal health, were also seen to negatively affect the completion of 6 months of exclusive breastfeeding. And since this is a conference where we have a lot of people who make decisions, who sit at policy level, that means we need a lot of energy in areas that strengthen. First of all, health program, maybe engagements in the local communities, or even in the health facilities. These programs which increase the level of knowledge of some of these mothers towards the benefit of these things will be important. Encouraging social support systems, like we talked about the husband involvement and other things at community level, is also going to be very important in improving on this. And maternal education is also something that we have seen that if we are to achieve the goals we need to encourage maternal education at some level. I will not take a lot of time. That was all I have for now. Let me take my seat. Thank you so much.
Thank you, Dr. Donald, for that wonderful presentation. Can we give him a hand of applause? Well, for now, let's note the questions. If you have any questions for Donald, please note it down. We will be wrapping up later. Our second presenter, Dr. Donald Dotto, please. You're welcome.
Good afternoon. I want to write on the protocol that has been said. My name is Douglas Dotto, and it's good to be here. Are you also happy to be here? Yes. Yeah, I'm very happy because I got to meet my former lecturer, Dr. Tim Tom. I think he last saw me in 2008 or 2009. And by then I was still I'm not yet eating a lot of tea. Yeah, thank you. So allow me to share with you one of my studies that I've done in regional referral. Dr. Bomi Felix, I think you did this some time back in 2018. And I was so what you did was so helpful to help me do this. I'm grateful for that. And I'm also happy to meet you finally. Yeah, so allow me to share with you. Let's go to the next slide in the interest of time. So I've been in the region for some time, about 8 years, and we have really struggled with family planning uptake in the region. And again, this is very, very low for this particular group, the vulnerable group, the HIV positive women. So for some time, we have been trying to improve the uptake of family planning among HIV positive, and the numbers, the things are not coming. So this prompted me to kind of do this study to try to assess what could be the, how are we doing in terms of utilization of family planning in the regional referral, but also what are the associated factors. As I earlier said, we have tried to integrate family planning into the chronic care, making sure things are okay, but still the uptake has been very low. So that's why I had to do the study and probably contribute to finding the solution. Next slide. So what was the objectives of the study? Just to determine the utilization of modern family planning methods. Of course, when you talk about modern family planning, WHO recently, I think 2020 made some adjustment to define the modern family planning methods. As of now, the methods that we used to know, natural family planning, the LAM, have all been classified. They're all under category of modern family planning. And you'll see from the uptake, probably the uptake you'll see is quite high compared to previously when Dr. Bomi did this. Some of those methods were not yet classified as modern. So we also wanted to know what are the associated factors. And of course, we focus on the social demographic, partner-related health system factors, and also social cultural. And this study was done at chronic care and EID at Gulu Regional Referral. Let's go to the next slide. I know, Sister Robin, are you looking at that photo? You're wondering whether that's you, that's not you. So be rest assured, for some reason, that photo is not you. So what were the methods? Of course, as I said, this was an analytical cross-sectional study. And we target for method mix. So sorry, it was also a mixed methods involving both quantitative and qualitative. We had 350 HIV positive women for quantitative and 12 participants for qualitative bit of it to complement the quantitative bit of the results that we will see. So that was picked through Kobo Collect. And we did analysis using the same approach my brother used, SPSS, PC square, logistical regressions. And for the quantitative, we did thematic analysis. As he said earlier, the model selection and the model validations, we set it the same as he said. P-value set at 0.02, and that is at bivariate analysis, and they were entered for multivariate analysis, logistical regressions. The statistical significance was set at P less than 0.05, and you'll see the results are presented in the adjusted odds ratio with 95% confidence interval. Let's go to the next one. So as you can see, the modern family plan utilization is at 68. I would say this is much better, correct? Yeah, I would be happy. For some time, when we were doing the utilization of family planning, there was a time we would remove condom out of it to give us some picture. But for HIV positive, we know condom is very, very important. So condom was also part of that. So out of this 68%, let's also take that about 32% we are not using family planning. And when I look at all the studies, including the one Senior has done, this has been the highest. I probably will try to explain it in terms of the reclassification of the modern family planning, but also the inclusion of the condoms into this. And the common use methods, as you can see, injectable, and this has been the common figures when you do analysis, simply because I think in our region they prefer the injectable because of the privacy, the convenience, and you can see also the male condom came in there, but also implant is setting in, as well as IUD. By the way, I am also so surprised with the uptake of IUD among this age group. So we're still struggling with the permanent methods, especially the male sterilization. So what I want to say, the take home is approximately 2 in 3 in every 3 women we're using a modern farming planning methods. And I think this gives us a bit of relief if we can maintain this. Let's go to the next slide. So what were these factors associated? There's significant factors, as I said, those who increase the utilization. We have partner discussions and a partner related factor with adjusted odd ratio of 3.44. And then privacy and confidentiality and the health system factors with the adjusted odd ratio of 3.39. But some of the factors that is affecting our utilization is unmarried women, as you can see, they're not utilizing the family plan. Then the strange thing is about the duration on ART. The more our mothers are on ART treatment, when they go beyond 3 years, they stop using family plan. That was very strange. So we need to pay attention. As you can see, 0.40. Then lack of knowledge, of course, we were asking for them somehow to be able to mention some of the family planning methods that they know, and we classify them into good knowledge and poor knowledge, and you can see. So waiting time more than 1 hour in the facility also affecting that. So in general, the health system and partner-related factors are the significant influence on the utilization. So the next slide is going to do a deep dive onto that. Next slide, please. This is a bit faint, and I know my seniors might not be seeing this, but I just wanted to point out that, as you can see, the marital status, the unmarried women were about 58% less likely to use family planning. Then the duration, and you can see the p-value as well as the adjusted odd ratio. So I'm going to share this so that my academicians can look at it. And then on the duration of ART, those who have stayed for more than 3 years, they're 60% less likely to use. And I think that's a true reflection. If someone has overstayed in the facility, is not interested in any other side, want just to get out and go away. So those who had the less knowledge and knew less than 5 family planning methods were 78% less likely to use. So not education, employment, and income were not significant after adjustment. So allow me to go to the next one. The partner related, what I wanted to point is just like I discussed, partner discussion with the FP. You can see that women who discuss family plan with their partners were over 3 times more likely to use family planning. Then partner approval, awareness, involvement, decision making, they lost significance after adjustment. So we need to pay attention to that. Next. Okay, so these are a bit of qualitative findings. So the health system, just waiting time. Sorry, go back a bit. My time is up, but just to emphasize, just like I said, more than 1 hour, 60% are less likely to use. Meanwhile, privacy and confidentiality had the odd ratio of 3.3, so 3 times likely to use. So allow me to, next slide, just to summarize. So these are just a qualitative bit of it to reinforce what we found out. But you can see the issues of myth and misconception is a big thing. And when we did try to deep dive, you can see issues to do with the family planning process, infertility, bleeding, cancer, they all fall in. But again, the other part, the partner support, reinforce what we had mentioned, that effective counseling at the facility, this could facilitate the uptake of family planning. So next. So as you see, the uptake has been high according to this study. Probably, as I said earlier on, this could be related to, there have been change, modifications, integrations, educations, and a lot of things have happened. But also the classification of the family planning methods could have also contributed to this. So we need to try our best and maintain this. Probably we could also do another deep dive analysis and try to see whether if some of these family planning methods picked out, how would we look like? Adequate counseling improves knowledge and utilization as well as, so these I've already discussed. Let me summarize with the recommendations. And sorry, I think, yes. So let's strengthen integrations of family planning into the care, especially HIV care. So for regional referral, we have seen the chronic care is on this side and the family planning clinic is on the other side of MCA. So we could bring it together and probably put if not together, or we put a simple units and a corner where we can provide family planning and help us to improve on the uptake. So for our health workers, let's try to improve on the client-centered counseling, address the myths and misconception. Male involvement is also coming in. As well as for community team, we need to increase community awareness, reduce stigma and misconception. Thank you very much. I would like to acknowledge so many people. Next slide, please. Dr. Boniface, you are somewhere there, Gulu University, and also, Uganda Matters University, where I was, I've sent this as part of the dissertation. Regional Referral Hospital also for giving me the opportunity to do the study, and the rest of the research assistant. Thank you very much.
Thank you, Mr. Douglas, for your wonderful presentation. In the interest of time, please note your questions. I would like to invite the next presenter, Ms. Adom Rachel. Please, the floor is yours. You have 7 minutes to make the presentation.
Good afternoon. Call Adom Rachel. I would like to present a study which was conducted in Teso sub-region, but why Teso, not in actually sub-region? Significantly, Teso and the Acholi sub-region have common points of interest, and they have undergone through similar challenges. Acholi sub-region had war. The same war affected Teso sub-region. Low education affected Acholi, at the same time affected Teso sub-region. Hunger affected this side as well as that side. So similarly, activity done that way, they are similarly the same. So this is it's about intrauterine device, and that is a family planning method. We can go to the next slide. So a brief information in this. Family planning itself is a key strategy to improving maternal health, especially the IUD is one of the most effective, and this actually is counted to be a reversible contraceptive device, and actually its effectiveness is about 99%. So despite its uptake, in many parts of the country, Uganda, this remains very low. So next. Globally, when you look at this, the uptake of this device is very low, and this counts approximately 14% of the women in reproductive age. However, in sub-Saharans, we learned that this is quite low than even what is at the global aspect of it. So what is it in Uganda? So when you look at in Uganda, the national prevalence of IUD remains significantly very low, between about 0.6 to about 2% of women of childbearing. So despite being highly effective and available, it constitutes only to about 5.4%. So this method, mostly because Ugandan women favors short-term methods compared to long-term methods. So the contributing factors for it being very low could have been misconceptions, inadequate counseling, a lack of skilled expertise to perform the procedure, and actually stock out. So efficient uptake in many parts of the rural Uganda has historically been also low, which include also Teso and Acholi sub-region. and also the same concerns as well. So this study generally assessed the factors contributing to the increased uptake of IUD at Soroti General Referral Hospital from 11% to 33%. So, and in this is using quality improvement midwifery-led approach among women of reproductive age attending services at Soroti Regional Referral Hospital. So, in this, midwives are the primary providers of the reproductive health and family planning services, and midwifery-led quality improvement model that focuses on strengthening, counseling, improving provider skills using clinical guidelines and monitoring service delivery may actually improve the uptake of intrauterine device. So in this method, which was used majorly played a quantitative approach and was conducted to review facility records and survey women attending the services. So the study compared the data from the initial low upgrade to that, and this was helping to identify the key drivers of that increase. So in those results, really it showed that revealed a significant rise in IUD uptake and improved significant client-midwife relationship. And in that, tailored improved privacy and consistent counseling by health workers. So continuous medical education, which help dispel myths and misconception among health workers as well. And in this conclusion of this study, IUD uptake from 11% to about 33% in the facility was largely driven by strengthened health systems, and that improving provider client counseling, improving knowledge of health workers through CPD sessions, embracing the technology, addressing misconception from the healthcare workers and the community as large. So thereby empowering women to make informed choices for long-term contraceptive method. So in that aspect, we look at a recommendation. So in the recommendation, we look at a weekly data presentation on local maternity and neonatal system. Why this hope to remind healthcare workers, what are we missing out? What are we not doing right? Which methods are being administered? Which facility is lacking? And that really would help so much in making sure that we avoid certain challenges that would come across things of utilization. At the same time, we learn why facility A is doing better than facility B. Acquiring research innovation on maternal child health prevention as part of performance appraisal. So in this aspect, it is so much interesting that when healthcare workers take this as their part of performance appraisal, you keep knowledge intact and you hope to guide to improve in day-to-day, especially on the prevention services of maternal child health. So increased utilization, radio talk shows, church, health education. Radio talk shows, I'm glad that we have the government ham available. Teso sub-region significantly uses the political time to provide this. And actually, I would really, that this can be a recommendation that we can use so that women outside get to know about family planning methods, and especially for intrauterine device, why it is important for them. So I need to support and encourage documentation journals, and in our day-to-day work in our units, this especially in postpartum family planning and postpartum family planning. So at all entry care points, we encourage CPDs and CNDs. This recommendation helps so much to keep people to date with the tracks, because the evolution of health today, it is at a rapid stage. So if you keep it behind, you may not get what is on the front. So by this, we keep getting to the new need regarding the long-term reversible contraceptive, especially the IUD, and actually redistribution of family planning commodities, especially the IUFD. And so, thank you.
Thank you, Ms. Rachel, for just one of the things. It's very interesting to see that the data coming straight from our registers. The format is what's actually on the ground. So for this session, we are going to have our last presentation. Of report, which I did a cross mixed study, and the mixed study is about institutional and environmental factors influencing the performance of nurses and midwives at Gulu Regional Referral Hospital. I did this brief study for 6 months. I've realized that there is a lot of suffering and there is a lot of manpower, lack of manpower. That's why I took this initiative. And as we are here, mostly the district head, the DHOs, the universities, the politicians, and all members, don't be surprised to see some of the few pictures. As I did observation, don't be surprised. It is for us to improve in the region, and we forge way forward and see what we can do. For those ones who have never gone to Gulu Regional, that is our gate. The background of the study, nurses and midwives constitute the background of healthcare delivery, particularly in resource-limited regional referral setting. Their performance they directly correlate with the patient's outcome, maternal, child, and survival rate, and overall healthcare quality. While individual clinical competence is critical, institutional framework and the immediate work environmental play a pivotal role in shaping healthcare workers' efficiency and morale. This study investigated the institutional and environmental factors influencing the performance of nurses, midwives at Gulu Regional Referral Hospital, which is situated in northern Uganda. The main aim of these objectives, the objectives are to evaluate the effective of institutional factors like continuous professional development, remuneration, administrative support, and staffing ratios on performance, to examine the influence of environmental factors that including workplace safety, availability of medical supplies, physical infrastructure, and ward management on performance, and identify correlation between these factors and quality of care in metric. The method which I used was a cross-sectional. I was doing observation physically and even getting information physically during my supervision. So for that, I did both quantitative and qualitative, which was adapted. The target population comprises of registered and enrolled nurses and midwives deployed across the various departments in the Gulu Regional Referral Hospital. The random sample which I used was quantitative, only 50. I took 50 because the duration is 6 months, as I've told you. And the structure questionnaire measured perception and institutional environmental factor. Then the key informant interview, guided
gathered deep contextual insight. Then quantitative data was analyzed using SPSS employing descriptive statistical and multiple linear regressive of determine the predictor of performance. Then quantitative data underwent thematic analysis
Excuse me, please. Kindly help us online. We are not hearing.
Yeah, thank you very much. Dr. Douglas, you mentioned that unmarried women are less likely to use family planning methods. Could you expand on that? Are they sexually active or not? Because they are in reproductive age.
Thank you, sir. I hope you've noted the question, Mr. Presenter. Do we have a second question for him? Cindy has a question? No. So we have one question for our second presenter. And for our third presenter, Ms. Rachel, do we have any questions for him? For her, sorry. Yes, Cindy has a question.
Thank you for your presentation. I'm just curious to hear from you if there were instances of discontinuation, but also among the people that you captured in your statistics, were they younger or older users? Taking into account that there's interest to also have the younger people take the long-term methods, if any.
Thank you, Cindy. We also have another question from Sister Ayo for the third presenter. Okay, thank you. Mine is not a question, but it is a submission for the second presenter and then the first presenter about the family planning used. What strategies have been laid to improve on the family planning update? We know that there are various factors that hinder the family planning update, but other consideration have been put up to ensure that we improve on the update. I did not hear about this one, which is very important, about the proper follow-up of this client to the facility physically after receiving the method, as well as the provider also should ensure that they provide the contact so that the client can contact you at any time and ensure that you give a positive response also to the client whenever the client calls you. Thank you. Thank you, sister, for the question. Now we are taking 2 questions for the last presenter. Okay. Dr. Kimber, is on my
Yes, thank you, sister, for your presentation. I'm just thinking maybe in your research, you could have taken a lot of literature reviews. My question is, did you come across something around the social lives of the nurses and midwives, other than just the environmental? You know, you focused at the workplace, maybe to inform the administrators at the regional referral. But is there anything about the social lives of the midwives and the nurses? Why I ask this is because in my office often so many nurses come, they want to take leave because of issues at home. You find someone is in a gaggle in a remote place, the husband is in Gulu, or the husband is in Kitgum and all that. So this usually brings a lot of instability in their social lives and also results into maybe inadequate performance because now they're taking emergency leaves and all that. So did you come across any literature to inform us along that line? But I appreciate what you've done. Thank you.
Thank you, Doctor. The last question for the last presenter.
Oh, thank you very much for the presentation. I have comments and maybe question to the last presenter. Thank you for showing us that the nursing division is having these challenges, which we know and we do experience as clinicians. And we know that the outcome of the patient is to be good, depend on the nursing care. But what you've shown here is probably an answer of the major issues. Has this work been published or shared anywhere else already or not? This is the question I have for you. Moderator, the first presenter made a very good presentation, and as mothers, there is something that I feel we need to share so that people who make guidelines and policies, which we always refer to WHO. WHO makes guidelines based on the experience that we get from the interaction and the studies that we do, and even observation. The 6 months of the exclusively breastfeeding, we have seen from your presentation that most of the mothers actually don't reach 6 months of that. And it is true. These children, when they reach like 3, 4 months, 5, and especially when they have other siblings, when they see the other siblings are eating, what do? They crawl, go for the food. As a mother, you will be tempted, and that is one of the reasons that I see is affected. But you can't isolate these babies. Now then, with these guidelines, are you aware of any work being done or WHO thinking of revising these guidelines? Can they shorten it? Many of the other guidelines and policies, because of the observation we have been seeing, we have tried to shorten some of the duration of certain specific implementation guidance. So this is my concern. Definitely a child getting a nice sense of food coming, they will go for it. And when you are not there, before you know it, they're already eating the food. Thank you.
But everybody said the head circumference is. I think towards food also the IQ is increased.
Well, we're going to have responses from the presenters. Please take a maximum of a minute for responding to a question. Thank you.
Thank you so much. I think 1 minute is going to be enough. This room today has a lot of exciting things. We looked at the head circumference becoming bigger and bigger. And now, men, I don't want to say fathers, men are sharing breast milk with their children. It's still a claim. It could be the father, it could be another man. We still do not know. However, I think it's very important. Now, this is why research comes in. We need to now do a qualitative study and ask these men, what is it about breast milk? Do you like it? Do you enjoy it? And what does the woman say? Does she complain? Or she's okay with it? Or she's reserving half for you and then half for the child and then being tempted to give additional feeds for the child. That is something that we still need to look into but that is exciting. And then the other concern was about whether or not grant multiplicity could be confounding Yes, now rank multi-parity could actually be confirmed because parity in itself is related to so many maternal characteristics, age, breastfeeding experience, socioeconomic status, even maternal health, something like that. However, in this study, we did not look at parity alone, but we included it in the model with other variables that had met the criteria. Therefore, our interpretation of parity was as an independent predictor. But also we could still not ignore residual co-founding from other things. Like when we talk of socioeconomic status, which the DHO actually made mention of, things like household income, which did not make it to be included in the model, could still give us some residual co-founding. And then maybe just a little bit on what Dr. Pascal has hinted on. Yes, it is very true that these are guidelines that were set, first of all, long time ago. Secondly, I'm not so sure whether we have the same reasoning in our local contexts. I do not know whether our children maybe grow faster or their metabolic demands are higher compared to those ones, or is there any benefit, or is there any risk actually of introducing other things, maybe a little before 6 months. However, I think last year, it may not be out here, but it was somewhere that exclusive breastfeeding could be considered optimal if we have 5 completed months. 5 completed months could be optimal, but still we want 6 months of life. So, and still, this means we still have more research to do as a community. That we need to look at our children here in our context, whether maybe 5 months is enough. And we compare with those who have gone up to 6 months and other things. Apart from that, thank you so much.
Thank you, Donald. We will move to the next presenter.
Yeah, thank you so much. Dr. Pascal asked about whether I shared my study or I published. No, I've not done it. I said this is still between us here. I've only given Dr. Jimmy Okay, my son, to go through. Then we publish it properly and we share it. Then to the DHO, you asked about the social life. There are so many. It cannot be included in my abstract. If I'm to include, it will be more than 400 words. But what I would like to tell you, there are a lot of complaints, like you get a staff coming to your office. For example, the staff is working here and the husband is in the Western Uganda, or the wife is working here, or the husband is working here, and the wife is in the Western Uganda. What else do you want? Definitely, they come crying. Who does not want those apparatus, doctor? They come crying and they come complaining, but there is no way because they have been sent by government, and you know how to get transfer back to the nearest regional hospital. Takes sometimes a long time. It is not like a district to district. We keep on solving the problem, and for the young one, we keep on encouraging them. Whenever they are off duty, they should go and catch up with their partners, but not to collect a fee. Thank you.
All right, thank you so much about the trace-time device. The instances of discontinuation, yes. The family planning method, the long-term method is ideally reversible contraceptive method, and it is administered to the mother according to her need. So, and it is tailored to prevent unwanted pregnancy, not too soon, not too late, and the interval. So, and in this aspect here, we have post-abortal family planning intrauterine device. You can discontinue it at 6 months. So, and like the same postpartum family planning, at 2 years you can discontinue it. So, according to the recommendation, recommends at least the child to be 2 years, then you discontinue plan for the next pregnancy. So discontinuation, it is there, but for the right purpose. So in this ones, possibly during the study, we had one discontinuation, which was due to gender-based violence. Age. Among the users, interestingly, actually, matured women are the ones who use an intrauterine device. That's from the age of 25 to 49. And the young women and adolescent, there is something cooking in the kitchen. We shall get to know why.
Yeah, thank you very much. Unmarried women, sexually active. My brother is a colleague of mine, a senior mentor, who one time told me that if they asked you, did you do it last night? There's a high chance you'll be like, no. So to be honest with you, I think that question I didn't ask, and I was also very sure that I was going to get a wrong response. So, but from what how I classified when it comes to married and unmarried, I had the married women and cohabiting classified in under one category. Married, then the single, widowed, and divorced, they were under unmarried. But I have a feeling from the discussion I had with them, the issue is about you are not married, and there is a belief that you should not be having sex, and you should also not be using family planning. So from the discussion, their point is, why should I take family planning when I don't have a husband? And I think we know very well, getting pregnant does not depend on the frequency of the sex. So this group of people, I want to say they must be sexually active. The only idea perception they have is, if I don't have a permanent partner, why should I enroll? And I think as health workers, we should prioritize them and make sure they understand that it's not about you being married, you can easily get pregnant. Thank you very much.
Thank you. That brings us to the last question for this session. I want to ask us to give a big hand of applause to our presenters as they move to their seats. Also, I want to hand over to the MC to give us the next steps.
Thank you so much, Jacqueline, for taking us through this session. It has been amazing and wonderful. And I strongly believe we have learned and unlearned a lot of things. And I'm sure we're not leaving this house today or this room empty-handedly. Thank you so much, our researchers, who really endeavored to ensure that they had something for us tonight. Thank you so much. So colleagues, it's exactly 3 p.m. and we're going to break for our lunch. And we're going to have a lunch of 45 minutes. And we get back to the room for the rest of the programs of the day. We are going to have our lunch down. All right, colleagues, we're going to have our lunch at the restaurant down. When we get down, we're just going to move this way. That's where the restaurant is. And ensure that you have at least a meal coupon so that You don't get disorganized. And also the appetite is disorganized. Yes. So at this point, I want to welcome our one and only representative from the biggest private facility, Ms. Joanne Ayet, to bless for us the lunch that we're going to have. Thank you, Joanne. Bless us, O Lord. Amen. Thank you so much.
Amen.
Hopefully we shall all enjoy them.
If I could turn it on, in case the person just wants the money now, the most important thing is giving the person money.
So for those that have not registered at the entrance, please ensure that you register your name with the right email address. We have the soft copy of our abstract book, which is going to be shared in your individual emails that you've registered with us in our attendance sheet. So please ensure that
Yes, Gillian, good afternoon. And then those one who are online, should we also register?
we are still empowered to even increase the standards higher. And you know, health centers really supposed to have now medical officers and nursing officers. So all these actually, I would say, empowers us. Another area to look at it is around supplies, essential medicines and supplies. You realize nowadays medicines actually come a little timely, and there's not a lot of delays like it was before. So this also makes us continue offering healthcare services to our people. And I would say we improved quality of healthcare services that we are offering. I don't know if I can continue speaking. I know another DHO is here. Yeah. But if I have to look at health financing alone, if you look at 2024-2025 budget, government allocation to the health sector, this is now generally speaking, government allocation to the health sector was about 4% of the total budget for the government. It increased to 8.1, though actually, I must be honest, I've not felt the increase like doubling from 4 to 8%, but actually, I don't know, but I've not felt that increment in the health spending by the county, which is a positive move forward as far as provision of health services is concerned. And I'm sure this always trickles down to the lower facilities. Allow me to request my colleague also to add some. The question is, how have we been empowered as a district to provide healthcare services to the district? Thank you. Please.
Thank you so much. Next.
Thank you, Dr. Kinto, for those wonderful remarks. I would like to say that the circumstances in your district are not really very far from the circumstances in my district also. I want to specifically zero the following. One, I want to talk about decentralization. The fact that healthcare delivery has been devolved to the respective districts, it gives us now the responsibility of providing primary healthcare services to the district populations. So this devolvement or decentralization gives us that authority. It gives us the audacity to do what we're supposed to do in order to provide the primary healthcare services to our people. Still not very far from that also is, I mean, these are we have the national health policies and also health sector strategic plans. These policies, these strategic plans, they help the district, they guide the district in the implementation of healthcare service delivery. Still also came to these national health policies. I want to say that having given us the mandate to plan, implement, and evaluate healthcare service delivery in the district, we are in a position to better improve healthcare services within the districts. Also, another item that empowers us is financial resources from the central government. Each and every district receives a certain amount of grant on an either basis from the central government. We know these funds help in the day-to-day operation of the district health offices. It also helps in acquiring some of those items which are needed in running or in providing healthcare services in our respective districts. Another item that actually feel also empowers us is the management of human resources. As a district, we have the mandate to recruit, deploy, and supervise, and actually manage healthcare workers. Given this ability to recruit, deploy, and even supervise, that puts us at an age where the human resource that you bring in, you you most likely to bring in the people that qualify or the people that you think fit the criteria that you want, which in the long run definitely empowers us as a district. Then still related to this is also the management of the health infrastructure as a district or as a department. You have the mandate to oversee the construction, the maintenance of health infrastructure within the district. So this puts us at an age where you know the health infrastructure that you want to have in place. You're in position to craft that kind of infrastructure that you want in the delivery of healthcare services. Lastly, we have a very important aspect of it, community participation. Now, within our districts, we do have health committees. For instance, we know like each and every, could be sub-county, could be the village, each and every of those units, they have health committees which help to bring out the community, which helps to involve our communities, right, to participate in the health of the population. Still also within our structures, we have VHTs, and we have public health education that is usually provided. All these items, they help to promote the involvement of our people in improving the health of our population. I think basically, like you said, these are some of the few
Please
items.
summarize and we go to the deal.
Yes, thank you, moderator. Let me just mention just one more very important that empowers us a lot, by the way. That is the presence of implementing partners in our districts. You if you look at the capacity of government alone, is not so sufficient to reach everyone. But with the presence of implementing partners, our arms at least is extended further, and we tend to cover a lot. I know Lamo is benefiting a lot. He has so many medical officers supported by implementing partners. So I'm looking at Cindy here will be from UNP FPA, but we're going to engage further and see. So many implementing partners really support us. And also the leadership of the district itself, the support from the CAO, the political wing, and many other stakeholders that we engage oftentimes to support us in doing our activities to make sure that we implement all these. Of course, in addition to the guidelines, most of these funding that come to us have guidelines that in a way also helps us from, I would say, from, for example, cows. If you find some cows would want a lot of money from it, but when you produce a guideline, or even politicians, when you produce a guideline for them, they now keep quiet. So I think there are so many things that are small that also still contribute in addition to the bigger picture of policies and other structure of health systems that exist in the district. Thank you.
Thank you so much. Can you appreciate the EHOs? These are the experts. The answers they have given, they are reliable because they are the experts in these areas. And we shall not doubt this. Now, do you have questions to the DHOs, the presentation they have made before we go to the Dean's faculty message? Okay. So
Yeah, thank you so much, experts, for the presentation and answer. I wanted just to relate on the presentation which was presented in the morning, more especially from our biostats, relating to the referrals and some of the death cases. more especially when they depart from the lower end facilities to the higher level. How are you going to improve on the areas that reflect when you see the number of referrals from the lower end facilities, moving health center 2, 3, and 4, and you find most of the cases are being brought to the higher level. At the end of the day, the higher level reports higher maternal death. How are you going to improve on this area? Thank you so much.
Next. Shall can set a limit of 3 questions to the DHO. Yes.
Yeah, thank you very much for the presentation. This goes to the DHR level. You mentioned about existing policies, and here we'll look at the human resources for health. Looking at the management of congenital anomalies, specifically craft food. We're having issues on this. Remember, our craft food treatment centers are only 3 in the sub-region, that is Gulu Referral Hospital, Kalongo, and Kitugu General Hospital. And we are having so many dropouts of children born with the craft food because of distance. And many of these are coming from Agabo district. And we've raised this issue to the ministry and made recommendations. Now that the DHO is here, in the morning we mentioned about having issues at Patongo, that they want to recruit an MO. We've made recommendations that if Agabo district local government can recruit an medical officer, this will help these mothers to ensure that they complete the duration of treatment. Because looking at Agabo as a district, distance from, let's say, Patongo to Gulu, then Patongo to Kalongo, that distance is too huge. So that's why we are having issues with the dropouts. And if you can follow it up to the District Service Commission, we shall be grateful. Thank you very much.
The last one, the DHO.
Well, thank you so much. Mine is in regards to the investment in infrastructure, particularly for the lower health facilities. I'm having a presumption that probably these health facilities as part of infrastructure are not well structured to cater for needs of isolation. Assuming we have identified an Ebola case at a lower health center, what plans do we have in mind as per investment into infrastructure to help support these small health units at the bottom? Thank you.
Okay, thank you very much for your wonderful questions. To begin with the issue of referrals, yes, yes, you asked whether how are we going to improve on referrals to make sure that most deaths don't happen at the higher facilities, right? Is that correct? In other words, I think you're asking about timely referrals so that they reach here not in bad state. But looking at it generally, there's one time we were in Kitugu district, Kitugu municipal, sorry, we are looking at all the different maternal deaths from the different facilities. When you look at them, some of them are really difficult, of course, to stop, but there are delays that would have happened somewhere in the middle. So one, we just have to build capacity about our health care workforce to quickly identify for referrals and referrals and the different facilities. For example, if they are to come from Patongo, the distance alone to Kalongo Hospital, for example, is also very difficult, especially during bad road, during rainy season where there is a lot of issues with the road. So that alone, there may be delay there. Some of them we can have control, but some of them the delay is just because of the nature of the environment. But timely referrals, this is what we always emphasize in our trainings for midwives. But also delays because of the fuel issues. I think some of these that we can control, we've instituted in ways of controlling. For example, at in Agamo district, all the center series are supposed to secure 500,000 per quarter for referrals. And then health center is supposed to secure 200,000 for referrals. If an ambulance comes and picks someone from your place, the money is already there. So such issues of a patient is looking for money for fuel and all that, at least those ones will cut short. And we hope that not to happen, so that if we make decisions of referrals and the technical staff have already asked the patient to go, they can quickly go. So some of those are the interventions that we're making to make sure that we prevent late, referrals, also management. So the only issue is how timely did you make, so that when they reach Gulu Regional Referral or the Cho Hospital, they are still in a state that the team there can save the mother. Okay? I hope I've answered you.
Yes, try to summarize.
Then the other one is about improvement in club management. We are supposed to make recruitment, and in our recruitment plan, there's an orthopedic officer, but we've not managed to recruit in the last time. So it means at the moment, because of many other issues beyond our control, we were not able to recruit. But hopefully in the few years, we will recruit. I know Agamo is very far. At least if we work on them from here, at least the reviews now can happen locally, not just to come back here. I'm sure you're right about the dropout rate, because for someone to come here is very difficult, especially if we are in Agamo district. So regarding investment in infrastructure and lower facilities, I think whereas there is existing policies on the health infrastructures, government is moving slowly, not at once, progressively. We're moving and building more infrastructures at the different health facilities. You find the health center still has only one building with 6 rooms. That is not very good as far as, because even if there's no isolation, still cannot be managed. So some of these we move progressively. However, in case of need for isolation, if we cannot move them to a larger facility like Pato Health Center, which may have a facility, we always encourage the team locally to isolate and create a place to isolate at the moment, especially if they have a limited setting. But I think this is a very important issue that we'll keep looking at. In case a facility has them, that's good. If not, we always move the patient away to a facility that can isolate, especially if it's a border. I'm sure we'll have a central point to make the treatment. Thank you.
Just to add on to the response, I want to specifically speak for Gulu here. As a district, we do have 2 constituencies. However, we do have only one CMOC facility in the district. Now, when you look at the referrals, the bulk of the referrals which do come from Amur are actually from one specific from one specific constituency, which is Kelak South. It doesn't have a CMOC facility, and there are a number of sub-counties there without BMOC facilities. Now, we in Kelak South, we cannot move from there and take our patients to Atiak because of the geographical location of Atiak. Now, for us to help improve on this large number of referrals to the higher levels, specifically Gulu regional and Lacho, we would like to have a CMOC facility put up in Kelak South. Plans are already underway. We've made a number of presentations. We've made a number of write-ups to the central government. And hopefully, probably before this year ends, we shall be having a project or other program by Dr. Dick, and most likely we may be in position to get a CMOC facility in Kelak South, and that will greatly help the population of more specifically can access. Thank you.
So.
Thank you.
The next part is the need. How the Department of Medicine position to transform healthcare delivery in northern Uganda. This is a strategies and question. Community transformation.
Yes, thank you. Thank you so much for giving me the time to respond to some of these questions. I want to start by saying that Faculty of Medicine is a faculty that meant to train the medical students for our nation. And in this aspect, it requires that to have some fundamental things that must be in place. I'll begin with the infrastructure. I must say that Faculty of Medicine currently is partnering with the other institutions, like Gulu Regional Referral Hospital, as well as the Cho Hospital. Now, these institutions provide the sufficient infrastructure that enable the Faculty of Medicine to train its medical students. Now, in this case, when we look at in terms of the labs, the classrooms, these have been got within these institutions. And then another level that I would like to say is the human resource. Now, for the Faculty of Medicine to deliver its promise to train the healthcare staff, staffing becomes very, very important. So in this case, we are in the process of getting many more staff who have been assisting us in this process. As I talk now, most of our courses have well-trained staff. Not only that, because we also share the staff with the Gulu Regional Referral and then the Cho Hospital, who help with the training of these medical students. So in terms of the human resource, I must say, as a faculty, we are ready and we are making use of this human resource to train the medical staff, medical students. Now, another level of transition of this region to provide the healthcare delivery, it now comes to the issue of students, the kind of students that we admit. We admit well-qualified, highly competitive students. As remember, the DBC was here, was talking about the kind of students that we admit in our faculty. They really perform very well. But in addition to that, we apportion some of these students who get very good grades. Some of them may not necessarily work with us here. So that's why as you remember very well, the DBC was talking about affirmative action that is always taken to admit the students in this region who come from this region, so that at least we have a pool of doctors when required can remain in this part of the country. So that to us is very, very important in the transformation of the healthcare service delivery in northern Uganda. Now, in order to train these medical students, we have the curriculum. The medical curriculum that we have is tailored toward the community. It is very, very, very good curriculum. And as I talk now, even the faculty, as we talk as a university, we are now in the process of revising the same curriculum to really focus on the community, rural communities. So this curriculum, therefore, must be tailored to the community health needs. So as I talk now, that is what is going on. We want a curriculum that provides sufficient knowledge, skills, and values to our medical students, so that when they go to the community,
they are able to deliver the right skills that and knowledge that is required by our communities. Then another level that I want to talk about is in order to provide appropriate healthcare delivery in northern Uganda, we have been following what we call community-centered approach. That's community-centered care. So in this case, our students, we take them for community placements. In the community placement, these are students that, who are usually in their fourth years. We send them for community placements. And that means community clerkship. They do their community clerkship in the health centers within the community. Now, this is because it provides them with the atmosphere of interacting with the community, so that at least they're able to appreciate the context of the healthcare needs that are required there, as well as they also provide basic healthcare support within those areas. So by doing that, they'll be actually trying to do a lot of work there, because when they interact with the patients, they provide the healthcare needs that is required. And then another thing that I also want to say is that as we prepare for this healthcare transformation in northern Uganda, the issue of research becomes very, very important, because many of these students, they also conduct research in their as a special projects in their fourth year study. Now, from there, they're able to do researches that they generate evidence-based data that can also be used to transform our community through maybe policy, because many of these students do very, very good research. They are supervised by their supervisors. And then when they do research, many of this research can be deployed to help in the community. For example, if they generate good data, that can even influence policies. Some of this data will also be published in peer research journals, which many people have been benefiting from that kind of outcomes. Another thing that could also be done is to strengthen this partnership with the health centers, because as I told you, when they go there, the university needs to support that activity. For example, when the students go there, there are certain things that they may need to use it from there. For example, the gloves and the rest. And so the university has been providing. So we hope we shall continue with that kind of partnership in order to make this transformation of northern Uganda a reality. So this is what I can say regarding that question. Thank you.
Thank you so much, the Dean. Let us appreciate him. As somebody at one point said, education is an industry whose products has to sell. So can we go to the next program analyst, UNFPA?
Thank you, Chair. My name is Cinderella Nena. I work with UNFPA as a program analyst here in Gulu. UNFPA is the Sexual and Reproductive Health Agency of the United Nations, and our mandate is largely very critical to this region. Our efforts are embedded within the government of Uganda, UNFPA 10th country program, which stipulates clearly our priorities of focus. And across Uganda, northern Uganda, especially actually sub-region, is one of the communities that are very strategic for our work. And specific to say, this focus is largely with clear evidence that we know the high levels of poverty in our region, the high fertility rates, the high unmet need for family planning, but also the high prevalence of gender-based violence. So some of those statistics and lived realities of our communities drive our mandate. Over the years, we have utilized the situation on ground to guide our work. So what are we doing to strengthen our healthcare service delivery? We are contributing significantly towards strengthening human resources for health. DHO Lamo just mentioned a part of what we do. And Lamo district is one of our focus districts under our 10th country program. We know that the defunding that took place for the better part of last year, but its impact this year has led to a number of health workers which were previously funded by other donors withdrawn, and that left a number of, for instance, refugee serving facilities, even without a single midwife in some of the districts. So we are supporting the districts to deploy health workers. We have about 10 midwives who are deployed in Lamo. We have a medical officer that we've just added at the start of this month. We have an anesthetic officer for Palabek Kalel Center 4 and in the other districts. And this resonates with the fact that the provisions for this workforce is on a short term, but our emphasis is on government to utilize available resources to get the staff onto the payroll. The other second and critical component, Kitgum district, I think Dr. Chula and Dr. Otto are not here, but we've also been supporting them to facilitate the district service commissions to sit and recruit. And I'm very happy that the commitments that Kitgum made for us here in this room when we had the regional performance review meeting has done. They have just completed recruitment of a good number of cadres. One of the challenges with that process that UNFPA came in handy was to address the issue of the service commission getting the resources to sit and recruit. So we're looking forward to AOGU getting closer to such processes, and we will be able to discuss and provide the support. At the policy level, we are very closely engaged with the ministries, departments, and agencies of our country to ensure that aspects of policy development, but also policy implementation are executed. So we offer financial support, technical support, but also most importantly, the implementation of those policies for healthcare service delivery. In the current reality, I think we have seen that the defunding and cuts in funding have also impacted supply chain and some of the essential medicines and supplies. A critical one that is important to us is the reduction in funding from some of the key donors for supplies like for condoms. You must have had Kitgum. There was a recent stock out of condoms, but also some other nearby districts. So part of our efforts in the country is to fill the gap and procure and ensure there is adequate supplies available in the districts. I also wanted to state that over and above, our work is integrated in nature and fits within the effort towards what we care about, and that is the adolescents and young people of our country. World Population Day is just 2 days from now. Uganda has a very young population, and for UNFPA, most of our work is that every adolescent and young person gets the care that they need to prevent any forms of actions that impede their opportunities to realize their full potential. All of you who are here were once adolescents and young people. Now picture the statistics that Raymond presented on adolescent pregnancy, which is quite worrying. And so a number of our efforts and investments in our $66 million US 5-year plan up to 2030 is seeking to work with government structures and systems to address some of those underlying challenges and issues at hand. The last one to say is we're also very particular on functionality of service delivery points. Patongo Health Center 4 is one of those health centers that UNFPA collaborated closely with the Regional Referral Hospital to ensure it was born and birthed and functional. Parabenkan Health Center 4 is equally one of them. And this is not just exclusive to these two districts, but we are broadly looking at ensuring the health service system in Acholi sub-region and Uganda meets the needs of its communities. Thank you.
Thank you so much. You have heard from experts. You can see the experts have a lot in store, so they cannot really deliberate everything in the interest of time. So let's go to the width of the RDCs. What government programs are there to support?
Thank you. The government programs that are there that supports, I think government of Uganda supports community, clinical care through several government national programs that are undertaken by Ministry of Health, local government, and the development partners. And indeed, in our respective districts, we have got several programs that are being undertaken by government through Ministry of Health. And here in the region, we have Gulu Regional Referral Hospital. All the districts' health facilities that are there implements all these government programs. And some of these programs are, we have the primary health care services that are provided in Health Center 2s, Health Center 3, Health Center 4. All this is to strengthen healthcare services. We also have programs like the maternal, newborn, child, and adolescent health. These and also the antenatal services that are provided for. All these are government programs that are in all these health facilities. We also have the national expanded program on immunizations. We always have a routine childhood immunization and vaccination period that we have across the country. All these are government programs. We have disease surveillance, disease surveillance and also epidemic preparedness, which help to strengthen response to the outbreak. For example, recently the National Task Force, which is headed by the President of the Republic of Uganda, gave serious restrictions and also directives were given to the district commissioners as chairperson of the district task force on epidemic to see that we reactivate our task force, says which all the resident district commissioners took this directive immediately, more especially across Acholi sub-region, who were able to ensure that everything is put in place. And there were also SOPs as far as schools are concerned, and everything were sent by Ministry of Health to schools. And more the areas and districts were zoned. Those areas that are located or nearer to Democratic Republic of Congo, all our border inlets were closed, like we have markets in Arua and so forth. All these areas were closed. and also districts like Lamor, district like Amoro, that borders the Republic of South Sudan, who are able to ensure that these implementations are done. So indeed, government also have introduced in health facility what we call digital electronic medical records. All this is to help us ensure that we do our work and the clinical care happens there and then. I think basically this is what I have for you tonight. Thank you very much.
Thank you so much.
It has been, Chair, I wanted to excuse myself because toward lunch, I developed a serious headache. But I'm happy I'm next to a senior medics here. He prescribed something I took. So when I came here, I was feeling dizzy a bit, but now I'm waking up, my brother. Thank you very much for taking care of me. Thank you.
Thank you so much. Let us appreciate him. So we're not going to have the second set of questions. This has been exhaustive. And it would be fair to allow the floor to ask a maximum of 3 questions. For the DHOs, they already responded to a number of questions. So if you have 1 each to an expert. Yes, Jonathan.
My presentation.
I decided to email.
So 1, 2, 3. I hope the questions are directed to one there, Jonathan.
Thank you very much, the panelists. My question will go to one to the RDC and the second to the Dean. In his communication, the DVC mentioned about public health, that it entails everything about human life. And this includes household incomes. So my question will be in relation to PDM and bias on the people with disabilities. So as a spedic department, we receive so many clients with disabilities, and their issues rotate around poverty issues. And as the RIC, we don't have statistics that these people receive money for PPM. Their money is eaten, and they have nowhere to go. So how can you address that issue so that these mothers and the parents can have a wonderful life? Then number 2, to the students. You mentioned about MOs. The school is excellent in teaching medical officers. Do you have plans to establish a bachelor's course for nurses and bachelor's course in nursing and midwifery? Thank you very much.
Next. What is number 2? PDM has entered health now.
Well, mine is extended to the Dean.
Yes.
I encountered a scenario some time back handling a client, and we could barely communicate. This client was deaf and dumb, and it was not the first scenario. So it pushed me to a place of thinking or stating a proposal. How about, as you plan to revise the curriculum, if at all it can be nationally recommended, that at least sign language is included as a course, because many medical personnel are struggling in that area in communicating with clients or patients who are unable to communicate back. Thank you.
Thank you. Azabu, what is number 3? There are 4 hands. Let us summarize
to know that deaf is for the mouth and the dumb is for the ears.
Enough. Thank you so much, Chairman, for the presentation. Mine goes straight to the RDC. In the Tol sub-region, I know we have traditional healers, herbalists, who are practicing actual medicine without certification.
And these are the people who sometimes delay our patients in the committee to delay the referral. Yes, the government hand, what does it take? Thank you. Okay.
Where is number 4? Oh, excuse me. Choose, I choose.
We have that.
And also there are those who come to hold the patients of Good Referral Hospital and take them to private facilities.
Yeah.
Which people should we use?
Thank you, Chair. Mine is just to the lady from UNFPA. Thank you for the support you are giving to the lower health facilities. But I pose my question that as a regional referral hospital, how can we get just a tangible benefit of services you are providing to the lower health facilities? You earlier on had one of the presenters talking about the shortage of human resource. Thank you.
Thank you. And this one was a representative of the president. This one is important.
Thank you, Chair. My question goes to DHO and I think UNFPA and maybe the representative of Gulu University. We've seen a number of government programs happening in the community. Let's say, for example, we had the massive vaccination. Is it the yellow fever? Sometime, I think 2024. But then there was a challenge that the community was not met. Not everybody got the opportunity to be vaccinated when it was being offered. Now, my question is to the three bodies. We have a medical school, university, training medical students in Gulu. We have various institutions as well, training medical students. Why then can't the bodies utilize this free labor? You know, we have students who can do this work. Instead of going with the few health workers that you have or we have in the community, why not approach these institutions and use these students when it comes to those sorts of programs? It will be cheaper and you'll have the work done because you don't have to spend maybe on a meal and transport, you know. That's my suggestion. Thank you.
Thank you. Let us,
Because of time
and planning.
There's a burning one.
One burning one.
This one's got to burn without a heat. Burning one. Please.
Well, thank you for the opportunity. It's not a question. I would really want to respond to the last question of recommending that we use students as free labor. Now me, as a teacher, I know that students must not work unsupervised. So students cannot be leveraged as free labor to solve the problem of workforce, unless these are students who are senior house officers. But if it is the medical students that we are training undergraduate, they are a liability and they are there to learn, not to be
Perfect. Every profession has a body that registers, monitors, and deregisters every profession. It's like that. Whether engineers, whether doctors, whether nurses, they are regulated. It is perfect.
So the supplementary force.
Yes. And a supervision, yes, for the learning purpose. The experts respond to those questions and we bring this session to an end.
Yeah, I'll begin with the last that question which I just been talking about, mass vaccination. I think students are highly programmed in their program at the university, and most time this process of vaccination may not take care of their program at the university. So by taking them to the field, I think they will be highly compromising their activities at the university. Secondly, they are also not qualified to do so.
because these students, this vaccination has to be done by qualified staff. So in this case, much as they might think they are free, they are actually not free. And even if they are free, they're not qualified to do so. That is what I can say about that. And then in regard to the program, Bachelor of Nursing or Bachelor of Midwife, I must say that as a faculty, we are developing a number of programs. We started with medicine, we went to public health, and now pharmacy. So now the next thing that we are now looking at is now that Bachelor of Nursing. As I talk now, we are trying to make sure that before we do that, we have the infrastructure to accommodate them, because
microphone.
Yes. So as I talk now, we issue about infrastructure become very, very handy when you to this NMA program. We now have the program for Bachelor of Pharmacy, and we are also getting some challenge with the infrastructure of classroom. So as we talk about nursing, we are now trying to come up with the curriculum, identifying the first of the technical staff that must be employed first before we can start that program. So once that one is done, then the next can be now starting the program, because there is somebody we have started the curriculum which can be worked upon. So as I talk, as I may say, is that it is in plan and it is in progress. When it comes to now the issue of sign language at the university, yes, I am the dean, deputy dean, faculty of medicine. Faculty of medicine. So I would, in my view, think that the sign language will probably be handled by another faculty, and later on we can use the product of that faculty to help in issue of medical interpretation. Thank you.
Thank you so much.
I'll be quick to the question asked on what UNFPA can do for the regional referral hospital. We're not able to deploy staff to the regional referral hospital at the moment. Our focus is on the underserved and hard to reach entities. But what I am sure of is we are very close partner and collaborator with the hospital, specifically the LMNS, which is housed at the hospital. We also engage the specialists to train the health workers in the lower level facilities. But I'm also happy to let you know that we've got an additional funding from the government of Iceland to have a fistula program, which will specifically come to the regional referral hospital for our region.
Great. Thank you very much. Yes, you talked about PDM, that there are people, more especially the persons with disability, that are being denied access. I think this is a program meant for all Ugandans. It's a program designed for all Ugandans, including persons with disability. And indeed, all the 39% of Ugandans that are outside the money economy are meant to benefit from this. And as resident district commissioner, I'm happy I represent my colleagues in this meeting. I'll be able to report this, but I would request that where you get challenges and have these particular cases, you do tap on us so that we can be able to mobilize, because they are priority. They are supposed to benefit from these programs, and nobody is allowed to deny them opportunity to get services from the government. So we need to work together, collaborate when they come to your facility, and they said they've been denied this. In any parts of the country, when you call on me, I'll be able to communicate to any resident district commissioner in this country, because we have our network where we are always together. Even if now you tell me to call Bunyangabu, I will be able to call my brother in Bunyangabu and say there's this and this case. There's this and this, and something will happen, because we are in a digital network where information can reach at any time. So please, let's work together in that field. Two, issues of traditional healers or herbalists. We also have their representative here. I had in the morning my good mother there telling you about the different positions she holds. Because during COVID, many of these people helped a lot. She even developed medicine. I remember meeting her in Arusha while talking about COVID. So all these herbal things work, by the way. Right? And I remember there was a friend of mine who had over 11 billion in his account. But after getting COVID, he called me from Kirandonga and said, my brother, now I'm dying, I'm going to leave this money. I said, okay, when are you dying? Can you give me the document? I'll have it. But I was teasing him. I drove there, picked him, brought him to Amuru, because Amuru was the epicenter. The only thing I did, because Professor Wang had not yet been cleared, but my brother, Dr. Mona, was the principal private secretary of the president. So he had given me some some carton of Covidex. So I had it in my district. So when I came with the gentleman, I gave him some 4 and he kept on dropping, and in a few days he was okay. He went back. So each and every time I keep calling him Mugenzi, the late, because for him, he had already called himself dead. So what am I trying to say here? There is a set of provisions of government. All these herbal medicines are regulated by the arms of government. It is only those who are not registered. There you can report them to us and we take action. But those ones who are registered and national and drug authority knows about their presence, they are doing the right thing, and they have qualified or they have documents from government that are satisfied their presence. This one we should allow them to work, because scientifically you're proof that what they're using is a known fact and it can cure something. So those ones, they don't delay. The only thing is sometimes is proximity. These people branch because of proximity. And you know that you, like in Amuru district, I have a sub-county called Lakang sub-county with no any medical facility of government, the entire sub-county. So before people come to Lacho in Amuru Center, they will first pass through these herbal centers and rest before. So you can't blame them as such. And we are working toward that. So I want to say that we cannot stop them. Only that I'm always not sure with these people who these traditional, there are certain traditional things, I don't know. You know those ones. That's the one I don't know whether they're satisfied or what. Those ones I don't know anyway. Mayor, have you heard something about that? Do they have certificate? Getting certificate, not double. Those ones I don't know. I've never seen their certificate. Because I remember one day we wanted to arrest a certain cow for mismanaging some fund in the district. The man drove direct. He left Amuru inside Buatira to Then we found him, we arrested him, he was inside busy, they were throwing something there, so, you know, this thing did protect the man. But they were waving it, when we were entering, they were waving at our side, saying, no, you just enter our vehicle and we go. So sometimes those ones are not registered. And I thought the wave would stop the arrest, but it happened. So please, let's encourage our people. I also request you, the medics, that please create an environment that people feel free to come to you to explain their situation. Because you are everything, you are the backbone of our health services. So you just create that environment, and every minute somebody will just run to you. You will not have time to go anywhere because you just say, we have so and so. I know facilities around Amor where some people feel free on a particular person. And when you want to transfer that person, they'll say, don't. So it's the same thing, that let's have that in our mind. I'm calling upon the DHO, please. It is your role to do all this work. Ensure that there is functionality of this health facility. That is all. Nobody will branch anywhere because you are all we have. I keep telling you, you are all we have, and will continue supporting you each and every day. Thank you very much.
Thank you so much. Thank you so much. I will stop by also sharing a story with you. When I toured Korea, one of the elders there say it's their culture. Because I asked, they say that the Koreans eat dogs. They say yes. One of the professors said, you see, the meat of dog is very similar to the proteins of human beings, so something like that. And then two, the father of modern medicine, that's the Hippocrates. We swear by the Hippocratic oath. Hippocrates, one of the principles he said, should separate the medical science from spiritual issues. And we still go by that principles today. I think the herbalists, they use medical science, not the spiritual aspect of it. And we have the Alternative and Complementary Medicine Act, which is by the Parliament, and it's ascended on to by His Excellency the President. It allows the traditional medicine to operate. It is in that act. And in one of the community, as we are growing up, even up to today, when you get a fracture, people will not even come to the hospital. They would apply their things there and it heals. So that's science. They're using science. It is not witchcraft or any other things. So we thank you so much for your expertise, and we hope to advance research. Research is a project. So thank you so much. MC, thank you.
Oh, thank you so much, Dr. Kota and team. Can you put our hands together to thank the Thank you so much. Colleagues, we shall have working tea for simply one presentation by Dr. Pepalo. As Dr. Kot is going, I must tell you that I was also in a place, you are lucky in Korea. I went in a village called Lachanpedine in Uganda. In this village, there's a medical practitioner who are flooding in Kona called Mukama Nayamba to get some drinks called Mukama Nayamba. And when they get the fractures, they go and they put things on them, and they tell them, you go home around 9 p.m., you sit in a place alone. Science will start working on you. And around 9 something, the president, you don't even see a person, you see them turning and crying. Science has gone extreme. Ladies and gentlemen, let us have working tea as we listen to Dr. Pebolo Francis, and this session will be managed by Dr. Bolega, the big man himself. The two doctors, please come up front. And those who want to stretch a little, who would want to take tea, please. But as they come, could we stand up? Because we have taken a lunch and we have not stretched. If I'm getting within the body.
Dr. Bulenga, karibu. You're also stretching, I can see. Turn to your neighbor and say, are you ready for the next one? The next one is going to take 12 minutes. Don't worry. It will simply be 12 minutes. But if you want the food to go down very well, take a cup of coffee and we continue. Dr. Bulenga, you're welcome.
Thank you very much, Pass. Good evening, members, delegates, all protocols observed. Allow me to introduce the next speaker. The next speaker is the specialist obstetrician and gynecologist, senior lecturer at Gulu University, and the Fogate Global Health Fellow, currently pursuing his PhD. He's a clinician at Gulu Regional Referral Hospital and is a non-researcher with over 50 publications in areas of maternal health, family planning, and post-abortion care. And not to play, he was among the lead. He was the lead of the team in Northern Uganda's first successful surgery for unadvanced abdominal pregnancy. He's a man who has great passion for the perineum. So, members, please allow me to introduce my teacher, Dr. Referral Francis.
Thank you so much, Doctor. The perennial part came on out. I thought it was joking. Yeah, thank you so much for the lovely introduction. I was invited to speak a little bit about what we have been doing, especially the project that we have and how we have been interacting with the teaching hospitals, but also beyond the teaching hospital. So I'm going to speak a little bit about how the project Faculty of Medicine is impacting on the transformation of SRH services in actually South Region. We actually, Gulu University, as been already said, I'm privileged that my dean is here, also the DVC was here, and quite a number of us are alumni, and then also faculty members and been contributing to the teaching at Gulu University. Gulu University dreams about the transformation of community. The community is the community we live in. It can be community wherever any of the product of the university is going, or any of the innovation of the university is impacting. At the end of the day, we dream about transforming the community. Next. Of course, Faculty of Medicine was formed in 2004. I think we are already now 22 years old. And by next month, we're 22 years old. We pride that the two teaching hospitals, the health professionals, the technocrats, the leadership of the district, of the region, actually work tirelessly to have us, to make us have faculty medicine. Where we sit as an office was actually a contribution given by Gulu Regional Referral Hospital. That was the old maternity building. The one was Central Police Station. And this is actually a big sacrifice for the establishment of faculty medicine. Like the hospital also contributed tremendously. They even built an infrastructure that we are still using now. That's what we are dreaming about. And this has a lot of impact as faculty medicine. Department of Reproductive Health, what I'm going to talk about is Department of Reproductive Health. Or Department of Obstetrics and Gynecology. It's a department, it's one of the 13 departments at Faculty of Medicine that has been interacting a lot more with the teaching hospitals. We pride that we are one of the departments that work very closely with the regional referral hospital, very closely with St. Mary's Hospital Lacho. We do a lot of things together. This is the only department where you find the staff of faculty of medicine, which ideally is supposed to be for all departments, listed on the duty roster for the regional referral hospital, as well as St. Mary's Hospital. So we actually so proud of us interacting together to make sure that we work to improve on health of our population. Importantly, in 2021, the Department of Reproductive Health tried to acquire funding to establish what we are going to talk about now, what we call Gulu University Sexual Reproductive Health Resource Center. This has been a dream that the department has been having for a long period of time, since 2017, 2018, when we joined the department. We started dreaming about having a resource center that will actually transform training, transform clinical practice, transform research capacity at faculty of medicine. So we pride that through funding from Center for International Reproductive Health Center, we are able to actually establish this. The faces there are many, and all the faces at Gulu Regional Referral Hospital, all the faces in St. Mary's Hospital actually are part of this. We also pride that Dr. Gomomin Felix, who is actually my good brother who is within here, is a member of the department. Matches is in medical microbiology and immunology. He's a very powerful member of the Department of Obstetrics, and he's actually a powerful member of this project that we are running. We have been running quite a number of projects in the department. We established that resource center in 2021, 2023. And then we had a very good project that we actually extended to all the teaching hospitals and beyond. And that is the research capacity strengthening project. And this has been a very interesting project. At that time, we were able to give seed grants to 28 members of faculty, including 4 from Gulu Regional Referral Hospital and 6 from Lacho Hospital. Each of them were given seed grants of $5,000. That's about 18, 19 million shillings to conduct research. And this research, I think, we already have data of over 20 publications that arose from those research. And we think these are data that should help us think more. The other thing is that we established the simulation-based training project, which kept upgrading itself. 2021, we established a simulation lab to improve on training. 2024, 2025, we were able to actually get what we call team-based simulation. We got funding from Simulation for Life at Mbara University Hospital, University of Science and Technology. So we were able to have that. Currently, we run a small project improving the quality of family planning and post-abortion care. It's expected to end next year. And this is a project that I will also talk about it, how it has been able to enhance our working relations with Gulu Regional Referral Hospital and St. Mary's Hospital Lacho, maybe later in the presentation. The other elements that I want to talk about is that recently we pride that we got another support from the consortium of medical schools in Africa. And this is to have Gulu University Simulation Lab as one of the implementing sites for simulation training for maternal newborn child health training. And this is a big thing because we were the only ones selected from East Africa So it's a big thing. Much as we sit far north here, we're also competing favorably in Africa. What we have is that importantly, we have a simulation lab. So any training, any DHO who is here, if you want to do training, we prefer training in the simulation lab where there are skills, where there are simulation that can be done. We can do simulation in the hotel like this, but in the lab, it's much better. With the regional referral hospital, we have no objection. We can have training with all this. With the Gulu City Authority, we actually welcome this collaboration as well. We have production studio. This production studio doesn't only produce lectures. We pride that quite a number of our midwives, nurses in Gulu Regional Referral Hospital were able to produce content. You've been antenatal clinic. You've seen those contents that has a logo of Gulu University. We produce those contents from our center. We have a center that can produce that. And for government centers, we actually welcome that idea. Of course, private, you know, as a university, there's still no way we can do business as a university. Until maybe there's a university holdings, we'll start working, maybe we'll start going private. At the moment, we're only supporting government-related projects. So we pride in that a lot. And then we have teleconference facilities that these gadgets that you see making things move around, these are actually our gadgets that we're using. So if you have a conference, we can actually do it for you. But besides that, if you go to the Gulu Regional Referral Hospital maternity boardroom, you see those cameras and then the screen. We're the one who actually provided that. So we can provide that. We have teleconference facilities in Gulu University, which actually help in doing teleconferencing. So as a department, we have these resources to make sure that we can be able to collaborate with people out there. Besides that, we have a number of things. Research club, we are able to establish a research club among students. And we believe that this will help reduce issues of sexual related problems among students at the university. We hope that this will spiral down to students in other institutions or even pupils so that they can have peer-peer relationship that can improve on their outcome. We have connections, we have skills, we have the right attitude. We have a lot of things that we do as a project. We've done quite a number of training, pre-service training. We've done pre-service training among students. We have a stipulated curriculum that we use for training. And in many things, we have this curriculum that we developed and we actually tested it. At the end of the presentation, I'll show you what the test was like and how it came out. So we have this, but also conduct in-service training. At the beginning of the project, when we had some funding, we were able to do in-service training for the interns. Before the interns rotate to the wards in Ops and Gyne, we have a 4-day structured training for these interns so that they are grilled on skills. And this has actually improved on the outcome of these people. Clinical service provision, we are actually able to support that. We were able to do the seed grants. Next. This is not to show off, but in 2022, we got an award. The Health Innovator of the Year awards, but also my brother, Bomomi. I could not write down your awards. I know you received so many awards. I just gave up on yours. So we have done these things, seed grants, and then also the other thing that we have done for Gulu Regional Referral Hospital is to support the establishment of their REC, Research and Ethics Committee. We have provided for them furnitures, office tools to have direct established. And I think that provision was since 2023. Up to now, we still have their projector and their printer, because we condition that until we see the office, we're not going to release the projector and the printer. So I think we have been negotiating with the secretary that maybe next week we're going to see the office. Maybe we can release their projector and the printer. And that's collaboration. We also want commitment. We cannot just release things and we don't know how it will work. At the end of the day, we want to do that. But also we provided training for REC in Gulu Hospital. In 2023, we had a number of people from Gulu Hospital who were trained as REC members. But also beyond Gulu Hospital, we trained REC in Lacho, REC in Gulu University, University of Sacred Heart, and Moroto Regional Referral Hospital. So we were able to bring experts to do this kind of training. And this is to support research in the region, because the more REC we have, the more we actually have ethically approved research, the more we actually protect the rights of our people whom we are actually collecting data from, and also the quality of this research. We also have, we do support conferences. I talked about this equipment, but also technical support. We have been running conferences around internationally. We have organized conferences for Center for International Reproductive Health Training. We have collaborated a lot when they were having a conference in Rwanda. We were the technical team who worked very hard to make that the conference successful. Last year, we had a conference here, which we won competitively. So it was also an opportunity to show. So if you want to also have conferences, you can talk to us. We see, yes, the other day I was telling my brother when we were talking about this conference, that we need to draw out all the most possible things that will go wrong in the conference. And then we look at them, how do we solve them? So we have done that. Up to now, I think, I don't know, the last bit of our manual vacuum aspirator are still there. Yes, we contribute to clinical service provision by donating manual vacuum aspirators to the Regional Referral Hospital and Lacho Hospital. And I can assure you, I am so proud that before we started this, Lacho Hospital was predominantly using dilatation and curative, which is an instrument that WHO said, no, don't use this. But now they're using this. We're actually proud of this, and it's a big thing, it's a big achievement to have that done. We also able to actually set simulation lab. A few months ago, our team went to Mbale to set up a simulation lab, Busitema University. So we have the technical support to actually have a simulation lab. Whatever simulation lab you want to have, we can actually do it for you. This is a setup of our simulation lab, artistic impression that we came with when we were planning to have the simulation lab. And it's one of the centers that actually people come to benchmark and see how we can make it. So we can plan and artistically have this for you. These are the number of seed grants that we were able to provide. 28, of course, at seed grants, you know, if you plant seed, some of the seeds may not germinate, or some of them germinate and then they wither because people are not providing manure. It's quite a big number, quite a number of publications came out of that, and we're proud of that. Now we're going to write a report. I think there's a report as to this effect, and this is going to inform us about it. Yes? These are some of the conferences that we had. Somewhere there between the I, G, and then G, O. Between G and O is Ope Jimmy. That was Ope Jimmy in Paris. So I think, and this one here, the one for last year, it was one of the biggest conferences. We attracted over 790 90 participants who join us in Gulu here. And that was a big achievement for us. Yes. Of course, we have had all these facilities. Yes. Some of the things that, some of the articles that I put here are articles related to what we have done with Gulu Regional Referral Hospital. I can assure you in 2018, I mean, I was at the AOGU conference, and then one of the persons mentioned that it was the report, the regional referral performance report was released at that time. And that someone said, Gulu Hospital has only 14% cesarean section rate. They are not working. And that was that question actually informed the first article. No, I think it informed that article. And that's how we are now, we're able to do another analysis to look at the driver. In the morning, we're talking about what are the obstetric population. The obstetric population of Gulu Hospital is very unique, very interesting. And you cannot compare it with other obstetric population. So we can't say 14 was not good. If you look at the perinatal outcome, when we had 14%, the perinatal outcome was actually better compared to some regional referral hospitals with higher cesarean section. So that means that it was not lack of cesarean section. We were doing the right thing at that time. Thank you. And then these two publication was related to what the simulation lab is. We just need to tell you that even if you enter and you see the simulation lab is very dirty, we have done a number of things there, and then the world is actually referring to it. How we use the training, the training tools. These are some of the things that came out of the training tool. We have had a number of collaborations in these years. We have had collaborations with all these hospitals, source collaboration. We have had collaborations beyond us here. Next slide. We have had collaboration with this other new university. Now we have some two new members. I've already talked about COMSA and then also Omeo University in Sweden. So, and then there are also a number of collaboration through our brother, Dr. Bogomil, that we actually added to this. And this is going to be a big collaboration because in this world of looking for money, especially in academia, you need more people around you who understand you, whom you have actually done something with. Because you cannot just aggregate a team that you call someone from Busitema, you call someone from there, and they say, you cannot actually write a grant. No. They start tracing. Who are these guys? Did they do any work together? Okay. So we have quite a number of collaborations. We hope that we'll build on this and make it better. Some of these pictures are just what we were donating. This one we are giving our manual vacuum aspirator at those days, 2021. Yes. This is the conference facilities that not the tables. Don't take me wrongly. Not the table. The technological things. Okay. Yes. The same camera that you see there, those roaming cameras, we have given one to Regional Referral Hospital with the screen system and then all the connectors. We call it PTZ cameras. These are some of the things that we produce. I think you know, this is a place that has been in antenatal for long. Okay? And the idea is innovative. The innovation here is that we believe that because there's low number of staffing everywhere, even at the university, we know government is like a father with many children. Cannot give you all what you want. Whether you want it like what, whether you have the biggest connection, government will also always rationalize. So in antenatal, the number of staff is not as expected. And then the staff had to do work. Whatever the case, they have to do work. And then they start rationalizing that maybe we can do this, we cannot do this. And one of the things that was heavily affected was health education, antenatal health education. Even if they give, they don't give it. There are people who also come late because the distances are different. The mothers come late, they're there. So we thought maybe the same midwife who works in the antenatal should be able to produce educational content. And at the end of the educational content, there should be a section of questions. So you will produce a number of educational contents for all based on the Ministry of Health guidelines. And then the same midwives who they see on the screen is also the one walking around. And she's the one going to answer the questions that patient will ask. And we think we have actually achieved quite a number of mothers increased antenatal attendance, and then mothers who started benefiting. You come late, at least you find something to hear from. And we thought maybe that would work. We still have this capacity, we can still do it. These are things that we also empowered capacity of our midwives. Some of our midwives went and presented at Kigali. That was an international conference. And we are so proud of that. So these are opportunities that can still be there. We can still present these opportunities. Yes. These are the models that we use in our simulation. These are uterine models. We want to learn how to do evacuation, the uterus, to learn on watermelon. Okay? By the time that the students or whatever is ready, the intern is already doing it, and if they know how you can manipulate. And we treat this as human beings. The human training of this is that you treat that watermelon as human being. So by the time, if we develop your attitude to the extent that you can respect inanimate object, then that means that we improve on that. You work better with human beings. Yes. These are the things that we're doing now. We're trying to look at quality improvements. We have installed TV to have health education. If you see that when a patient comes to the hospital, they spend maybe 5 minutes speaking to you, but they stay 24 hours in the hospital. Nobody is talking to them about health education. How about if there is something that is there and is teaching them? Not this time where we put a Nigerian film, or some Indian shop. We've done this. We've also had quite a number of POA projects, which I think is not working very well. We need to first brainstorm ourselves and see how we can improve it. In Lacho, it has speak very well, but of course, there's differences in the institutions. So we need to learn and see how we can make it better with us in Gulu Regional Referral Hospital. The other thing is, of course, we are dreaming of having a one-stop center, and that is a big dream. Of course, we already had a number of engagement, and then we have allocated, and we're supposed to already renovate. But of course, these are two institutions. One is Ministry of Education, one is Ministry of Health. So this has been a very big thing. I have had the biggest headache in this project. I don't know how to move around, but I think we are going to overcome in the next 1 or 2 weeks so that we have that renovation done at Regional Referral Hospital. The old maternity building, what to dedicate a one-stop center. A woman enters, finishes everything, goes back home. Not these things of inter-department referrals. Go there, go there, go there. They go there, people will run away. Because I go to see the next person, I go to see Rachel, I develop a report with her, then developing a report is very tedious. So we believe that maybe if we have a one-stop center, will actually produce more data that will help us to have a bigger one-stop center in the future. And we'll look for the money, all of us will look for that money to have one big one-stop resource center. Okay? So basically that, next. Challenges, of course, we have delays in the renovation that I've already talked about. And then the poor uptake, especially around the QI. And then the screen utility, we have put this screen last year when I was still in somewhere in Sweden. Up to now, the screen, some of them have not been put on. So we did give you as a challenge. Let us utilize the screen, please. But of course, the opportunities there is that with this, we can work together to improve on the QI, the research. I'm happy that REC of Gulu Regional Referral Hospital is now coming up. And I think with this, we can work together to develop that. But also, we can work together to mobilize resources, government resources, stakeholders' resources. We can work together. And the bigger the collaboration, the bigger the partnership, the better will be the negotiating capacity. And then, of course, we can also increase on the visibility. All of us will be seen. And that's the opportunity that we have. And then maybe it's also collaboration so that the hospital, the institutions can collaborate within the software. And then we can build a better, cohesive working environment for all of us. We need to work when we're happy. We need to deliver to change the world. Most important thing in this world is if you're going away 6 feet, you should leave a legacy behind. The legacy should be something that you've done very well, that people will remember you for. Not for bad things, for being a book or something else, but the big picture now is this one here. We're working on this, and we think this is the big elephant in the room. If we have MBED programming upstream, even the figures that my brother presented will change in the morning. It will change because we will have workforce that we were looking for. In pediatrics, I think the picture is not that bad now. Okay? So when we have these people, it will make sure that we have human resources available all the time. And then also errors will be reduced. And also we're trying to work, as Dina said, we're working on Bachelor of Science in Midwifery. And that will be born in our department. We'll divorce it when they graduate. On the day of their graduation, we will tell them, okay, now you can go and establish your own department. And we're negotiating probably in the next financial year as department, as Faculty of Medicine will negotiate with the management of the university to employ some people to actually run this program. We can not start the program if we don't have some human resources in the picture as a skeleton. So it's important that we're really looking at that. I thank you so much and have a good evening.
That is not the limit. Thank you very much, Dr. Mibalo. Yes, that's pertinent issues, especially the last one of introduction of Masters of Medicine or BGY. And the other things which look minor, like the donation of manual MVA sets. When I was my internship, where I did internship, there was only one MVA, and it was being kept by the NHS. If you have a mother, you want to do evacuation, you have to
wrote for the any child, so that you request so they give you use that to take back. And when I was for training in Gulu, we had very many, so I was surprised. So he has presented. It is now open for questions and additions.
Thank you very much for the presentation. Yeah, you mentioned about the one-stop center. You started in high gears, then finally you went down. No communication, no what. You've written it briefly, but please expound on it. Why is it delaying? Then too, you talked about non-functionality of the screens. You donated the screens to the hospital. Why are they not functioning up to now? 1 year plus. Next. Okay. Not seeing hands up. No.
Thank you. Mine is on the issues of publication. I think that is an area I want to encourage you that more effort is needed in that field. Thank you. Thank you so much. Mine is not a question. In a gathering like this, it is also good to recognize the tangible achievements that have been made and can be seen. Me and Dr. Bulega here were products of Gulu University, and we passed through that department. And one thing I got to learn when I was rotating in OBGY is that the Department of Reproductive Health plays a very integral role in Gulu University, in Gulu Regional Referral. Actually, you cannot differentiate whether this one is a university staff or this one is a Gulu Regional Referral staff, because we consult them. Sometimes we are stuck on table as interns, even at 2 a.m. But you will find that even the Department of Reproductive Health is embedded in the timetable that they are able to respond to these obstetric emergencies as fast as they could. Sometimes, due to logistical and transport issues, there could be challenges in trying to access these specialists, especially the ones on the university side, because they don't reside within. So this is an appeal to the hospital management that for the future purposes that a transport means be designated such that they can easily be accessible in terms of need, because most of them don't reside within the hospital quarters. Thank you so much.
Thank you, Dr. Byron. We also have the question online that how can someone join the research training program?
Yes, thank you, Dr. Febalo. I want to know how can we as districts benefit from your department? I know you do training, and all these people you train may at some point end up with us at the district. But it's also best if you can also train the existing staff to build that capacity at the district level. How can we work it out? And we also benefit with the existing staff. Thank you.
Thank you very much. Your question is on, I thought it was summarized in him.
Thank you so much, Doctor, for the wonderful presentation. I'm so much interested in the teleconference installation. What I know is maternal child health department always have this gazetted place for cesarean section within the department. So are we able to do actually telesurgery as well? And if we have not, is it one way that we can look towards that you can sit at the comfort of your place as you supervise the interns in the operating room?
After this one, more 2, 3, then we summarize.
Okay. Thank you, doctor, for the presentations you have given us. It has been very engaging. I am a stakeholder among persons living with impairments. And many times we get a lot of issues from mothers with impairments, especially physical impairments. I wanted to seek your explanation. What's your experience with those mothers in the sexual reproductive health? Mothers with severe physical impairments or even other impairments. Thank you.
Okay. Begin with Madam Solomon.
Thank you so much. Thank you, Dr. Pebalo, for your elaborate presentation and the work done. I have I don't know if it's a request or a suggestion. I don't know if you can also extend the REC services, like for example, to Gulu College of Health Sciences, where I'm in part, because the students do a lot of research. I think we do about 60% of them usually do their research projects from Gulu Regional Referral Hospital. So I think I am requesting that you could put up us in your program so that maybe our team can also benefit from the REC. And then also on the issue of the televised equipment, can we also at some point have access, because with the new curriculum that we are running now, we should have stimulation labs that can have visual. Can we also access some of the equipment if requested for to enhance the training of the students? Thank you.
Thank you, Madam Solomon.
Yes, thank you so much, Dr. Pebalo. Yeah, so I'm coming from the angle of the private setting. I've heard you talk about Gulu Regional Referral, and now the clinical school is coming through. I want to know how open you are to collaborate with the private health facilities, because I also stand in that bucket, though ours is a not-for-profit. We're looking forward to having such a collaboration come through. Thank you.
Thank you so much. Mine is going to be very brief. First of all, you made mention, Dr. Pebalo, that the Department of Ops and Gyne works closely, actually is integrated with the department from the hospital. And we have seen a lot of success coming from that integration. Is there any plan, or good enough the Dean of the Faculty of Medicine is represented and the hospital administration is also here, that other departments could also buy or borrow the same leave and offer the same kind of support to the hospital? That would help not only the patients, the students as well, and other people who are consuming these services. Thank you.
Thank you all for your questions. Doctor, you can go ahead and satisfy the needs of the questions.
Yeah, thank you. I hope there are no more other questions, because I'm standing between you and your tea, red tea. So, yeah, Dominic, thank you so much. Yeah, we developed this model of integration as a way to show the other departments that we can actually do it. And I think how this can be done, the dean is here, probably has gone through the MOU better than I did. So probably it goes back to the MOU. Sometimes what you're providing is actually stipulated in the MOU, but do we all understand the MOU? Okay, that's the other thing. The other thing is also how you relate. If the clinical team at the hospital work together with you, you're likely going to work together with the clinical department. But if people treat you like you are a semi-foreigner, probably the kind of reaction is different. So it's both sides. I think we need to learn ourselves. We need to see where we can work together, where we cannot work together, and then maybe improve on that. My brother from the private sector, Gulu University is building what they call Gulu University. I'm not a spokesperson, don't quote me on this, but I think there's what we call Gulu University Holdings. That has been the pipeline. I don't know if it's approved or whatever is happening with that. Because as a government institution, it will be very hard for you to operate businesses with private sectors. Unless you're just going to do to help support the private sectors. At the end of the day, if we are coming from the point that we are going to support or help the local population as part of the community transformation, maybe from that angle we can have that. Yeah, but for now, working directly with private sectors might not be an easy task to do. How can Gulu College of Health Sciences be able to benefit from this? Normally, all the training at the simulation lab or all the recording at the production studios are actually booked. Gulu College of Health Sciences being a government institution, I think we can still benefit from all these services. And if I'm not wrong, there's an MOU that is between Gulu University and then Gulu College of Health Sciences, especially as far as pharmacy training is concerned. Maybe we can explore this in a similar way. If we need simulation training, you can look at it from that angle. You can contact the faculty administration, and then it spiral up the administration, and you can have that MOU, and then you're included. I think that's something that we can work together to make sure that we all benefit from that. And then that also help you to have access to the televised services. We can have those things. These equipments are there. Sometimes we don't record for a week. The uptake is a bit annoyingly or unfortunately not as expected. Many people don't like cameras. You know, most people when they go before camera, they first need to, you change even your tone. So because of that, maybe we need to look at how to make it better. Yes, Lord Mayor, thank you so much. I am actually doing research. My PhD is maternal health care for youth with disabilities, and I'm focusing on Northern Uganda. And I'm trying to look at the challenges that they go through when they are accessing services. It's a big challenge. The DHOs are here. I don't know if you have any sign language interpreter in your district. The last time in Gulu Hospital, we have the people who learn maybe on job. I mean, they know it. But is there someone who is dedicated to do sign language interpretation? But you see on TV, on UBC, you find someone is doing sign language there. But in the world, one time when I went for a camp in Lera, there's a lady who came, who not speak, only doing sign. I have no idea of any sign language, trust me. We had to wait for an hour for someone to come and interpret. So I think this goes with what they were asking the dean. This special needs education needs to be important. But also importantly, I think our providers are not equipped to provide services to all different forms of disabilities. I was analyzing my data. One of the participants said, the provider from our hospital here, by the way, told her to go and do exercise by walking. But this is a cripple, someone who is crippled. If you look at our delivery beds, they are standard, high there. You have to carry someone to put up there. Antenatal beds, they're similar for able-bodied persons, not for us. So I think we still have a lot of problems to solve. Maybe we need to start looking at how we can help those people. Rachel, you asked something about how we can do telesurgery. It's a good idea. We had thought about this, of having our theater room actually equipped with these facilities. We hope if in the future we get some grants, some funding, we can think about that. But you see, the people who give grants, they don't know the problem you have. They perceive the problem you have is not that one. So we hope we'll convince one funder one day to have that. But one time we did telesurgery through WhatsApp. And it worked. We were all in Ginger. We were for a training for the EXACO training, East Central and Southern African College of Ops and Gyne in Ginger. And then the medical officers were stuck in Gulu Hospital theater. Network was bad. We said, put on light, stand somewhere. We were instructing them, do this, do this, do this. But we were successful. We don't know if it was luck on us or the patient was not meant to die, but the patient did not die. We were able to support. But I think it's a good thing we can think about. It may not be the immediate priority now, because also you need internet connectivity, which I think at Gulu Hospital now we have better internet connectivity. Looking at the EFR, which is doing marvelous at the moment. Maybe you can leverage on that and should be able to work around to have that done. Kinton, thank you. Actually, Namur benefited from these recording services. There was a time we went for support supervision in Namur. We took some of these recording services to the health centers and distributed. And then also, we believe that some of these things can still be done. It is upon you as a district plan with your team to see if they want to come to work with us. You let the head of the department know about that, and then you plan with them. Because it might need some 1 or 2 days of having this. Because you need to first write the script, recite it. We do dry run before you start recording. And the recording might also take some time. So some of these services can work, but also besides that, the training, we have no problem providing training. If you let us know that you want to have training that need to be done, you just let us know in advance. We book for you the space. You bring for you your provider. If you want us to train, we can do that training. Or if you have some implementing partners to support you in that, we are happy. We have done this for Lira, for Lamu sub-region. We have done this for even West Nile sub-region. They informed us early, we planned for them, we were able to do it. But of course, with some implementing partners. And then we will be very happy to work with you, because that's the heart of community transformation. If my people in Agago do not get a bad outcome, I'll be happy. I think everyone's be happy about that. Yes, my brother Osborne, I think publications is something that we are trying to work on. And there's something we have been talking about with Bomi. Maybe we need to reactivate this, what we call, there are some people who train us what we call pre-publication services. These are services that are done to enhance publication. You write your manuscript, there will be a team of experts that can peer review to improve on the clarity, the whatever, so that when now it goes to journal, it has a higher chance of publication. Trust me, in the publication world, the worst mail you want to receive is, we regret that your manuscript You're not going to recover. Me, I don't read the mail all. When I read, we regret. That's the end. We move on. And many people, when they have, my friend Jackie, when she receives, we regret, she posts that manuscript for like maybe a month. She's not going to touch. And I believe some people even post it for a year or forever because of the simple rejection. So I think maybe we need to look at this. We, as some of these experts, we do a lot of peer review processes for international journals for free. Like for me, in a year, I review more than 20 articles for international journals. But now, if we use all these knowledge, resources, and work with the team that are known to make sure we actually review people's manuscript and improve it, I think it will help us to make better people, to mentor people into the publication world. But of course, the issue is people are still scared because of pirates. We grew up in institutions where there are so many pirates. When they get access to your research, you're gone. They will get it. And then the next time you see another thing that looks like your child moving on the street. So that's the biggest problem. Yeah, the delay in the process of having the renovation done is technical. Probably, I think the project committee will meet next week and discuss the technical details. And we need to meet and decide on what can be done next. Now we have answers to all the technical things. Because as I said, university is Ministry of Education. Hospital is Ministry of Finance. Ministry of Health. So problems only. That's arising. And then the screen, each of the units were supposed to produce videos. And they have contacts of the person who is in charge of the videos. Maxwell is the one who runs the servicing, is around here. But because of maybe work schedule, maybe because of, I don't know what else, many of the people were not able to report anything. So that's why the thing is not functioning. It is at the docket of the institution. We already donated this equipment. We're not going to claim it back. If we give it to the Guy Ward, it is for Guy Ward. It is Guy Ward to make sure it is functioning. Okay? Even the data that we want you to display is not for us. We don't want the data. We don't even take your data. We want you to come to the hospital and see, this week we've done very well. And the data is the one showing you. So it's upon the unit department to produce this data, like the statistics. The statistics that my brother projected in the morning here. Each department can project these statistics at their department. And that will help you to know. So that if someone comes, especially journalists always think we don't do work by the way. I don't know if they're here, but even if they're here, they should hear this. But if they come and see there's a data display, it works. Maybe we need to benchmark with Lacho. Lacho is doing a wonderful job. You actually go there and see, hey, this week we've done this is great. Then they work towards improving that. Thank you so much.
Thank you so much, Dr. Bebaro, for that wonderful presentation. Although there was somebody from Agabo saying they have never seen you there, that you should remember them maybe and go there and donate some of those materials. Thank you very much. Can we give Dr. Bebaro a big hand clap? Let me return the microphone to the female MC since I'm male.
Thank you so much. Thank you, Doctor, for being a gentleman. All right, colleagues, it has been a very cheerful day. And finally, the sun is going down to set. And we also want to relieve ourselves so that we go and have some rest, so that tomorrow we come back when we are fresh and ready to learn again. So we have come to the very end of our presentations of today. And without wasting time, we're supposed to have a closing remarks from our hospital sec, but I see but because of other reasons and other engagements, he had to leave us before this time. So in a special way, I'm going to welcome the chair organizing committee for this program, Dr. Jimmy Ope, who is going to stand in for the hospital sec to give a closing remark, who then will invite a person of his interest to give us a closing prayer. And tomorrow our program is going to start at exactly 8 a.m. in the morning. And we encourage all of us to be here early enough so that we don't reach this time. At least by 4:30, if possible, we should be closing.
Yes.
Thank you so much.
Yeah, thank you very much, our dear MC, the two MCs. I think they're still all around. May we give a very huge applause to them, please. Thank you, Mr. Oya, Walter, and Miss Joyce Pio Gillian for taking that through the whole day. I know it's very, very tedious work, but you accepted passionately to ensure that the day ends in a very style, very good way like this. The director has communicated. Also, the director is not feeling well, but it's getting better. The deputy was here and he had to go, being an orthopedic surgeon and with the accident that we had. So he has so many patients to attend to. And that's how we realized they left. But we are here together. I just want to thank all the presenters. Can we clap for all the presenters, please? Thank you very much. The panelists, we clap for all the panelists. We here to answer questions. And please let us clap for the organizers for this conference. Thank you very much. The IT team, they're doing great work. They're being seen out there and this is actually streaming live on YouTube. So when you are here, you are international. You're not just in Gulu City alone. You're international, you're being seen everywhere. So clap for yourself for coming. I've had the opportunity to meet all of you great delegates here today, and we are looking forward for a more engaging discussion tomorrow. And as we summarize the last day for our conference, but we hope that all of you will return here in good shape to ensure that we sit up on the knowledge that we already have been having. I am not the director, of course. I'm the chairperson of the organizing committee, but as Dr. Pebala has already communicated, the school, the Gulu College of Health Sciences, you've been sending students to come and collect data at Gulu Referral Hospital, but with the establishment of the REC, that we intend to have it fully accredited, is that we'll continue supporting the students to review their work. And I know the students are already giving you feedback on what we have been doing to help them as a research and ethics committee, because we realize that there's need for us to have a lot of discussion with the institution around that send the students to do research work, because we also want quality, something that can move them. And the principle of research cuts across the same, whether you're doing it for masters, for undergraduate, for PhD, it still remains the same similar methodology depending on maybe study design, where people study from, and all these aspects. So I think that is very, very important. And I thank you for, I've been looking for you actually. I thank you for coming. We hope to have more engagement. Let us wind up this evening. I believe that you have learned a lot. Personally, I also learned a lot from all of you, and I'm still looking forward to learn tomorrow. So without much ado, I would like us to retire and we go and freshen up. Make sure we come back tomorrow earlier late as we've been communicated, and then we continue engaging ourselves. It's wonderful discussion. Thank you very much. I wish you all the best. Enjoy your evening.
I think we invite Bruno to give us a closing prayer. And after the closing prayers, if we go out, the MCs can take a group photo of MCs. The cameraman always forget MCs. You know this very well. Can you stand up for a while? Closing.
Thank you very much for giving me this opportunity. May we please rise up, humble ourselves, and speak. In the name of the Father, the Son, and Holy Spirit. Father, we want to thank you so much for the gift of life and good health that you granted to us today. You made us to see today, not because we are good people. Many of our friends have not made it to this day, but because of your love, you have made us to reach at this particular moment. I want to thank you for all that has transpired in this conference. We have had presentations from experts. We now pray that, Lord, may you open up our minds so that we may go and put into practice what we have learned from today's session. I want to commit our lives into your hands as we have come to the end of today's session, and pray that, God, may you grant us good health, protect us, take us safely to our various destinations, and that will give us the wisdom to go and implement all that we have learned. Bring us here tomorrow safely so that we may continue to attend more of the presentation yet to come. I say all this in Jesus' mighty name. Amen.
Thank you, Pastor Bishop. Bruno, please let us have a great evening. Remember, tomorrow starts at 8, being a Friday. We should be closing earlier than 4 o'clock. God bless.